again, welcome to Women in Data Science Kenya Conference 2024. We are super excited that you created time to join this inspiring event. Honestly, I'm overwhelmed because this is like the most attended since we started hosting WiDS events to promote data science here in Kenya. And so thank you and thank you and thank you. And trust me, first of all, to all amazing ladies in the room, happy International Women's Day to us. And in this session, we have wonderful and phenomenal women who you are going to hear from. These are women who are doing super, super well in the field of tech and data science and AI in general, and you don't want to miss a thing. So stay tuned. Even for those of us joining us online, I hope you will make it to the end. We will try and accommodate you as much as we can so that you feel in all throughout the time. I know it's so hard to stay on the call for a very long time. So we are already past time, and I'll just go straight. So first of all, we will start by having our opening address, and this is going to be delivered by one and only Dr. Lilian Wanzare from Maseno University. Dr. Lilian is a lecturer in the Department of Computer Science at Maseno University. She is the current head of the department overseeing the department's teaching, supervision, and mentorship programs. Her research interests are in artificial intelligence and machine learning, in particular, natural language processing and building text processing tools for low resource languages. She holds a PhD in computational linguistics and Master of Science in language science at the technology and technology from Saarland University in Germany. She has served as the principal investigator for research for several research projects funded by Lacuna, IDRC, AI4D, among others. She has pioneered the CanCorpus. We all know and we all love CanCorpus dataset, which stands for Kenyan Language Corpus for Natural Language Processing and Machine Learning Research. And the project looks at building data sets for training NLP tools for under-resourced, underserved languages, particularly those spoken in this country, Kenya, with use cases geared towards agriculture, education, and health. So please allow me to share Dr. Lilian's slides in just a moment. And then Dr. Lilian, please take it away. And if you don't mind, please turn on your camera.
Thank you, Millicent. I hope
can you see your slides?
Not yet. They're still loading.
Okay, in a moment you'll be able to see them. We can see them. Cool. Go for it, Dr. Lilian. Over to you.
Yeah, thank you so much. I have how many minutes? 10?
Yes.
Okay. So thank you, Millicent, for the intro. Thank you, everyone, for joining. It's great. I wish I could have been there physically. It looks packed and with very enthusiastic faces. So I chose purple for royalty for today for the Women in Data Science group. So feel royal, feel entitled to be here, and feel most welcome. So all of us are welcome to this event, both men and female. So our focus for this event is AI, equity in healthcare. So that theme really is packed, okay? Because we're not only looking at AI, but also looking at equity, and in particular in healthcare. And that is an interesting way to start this particular event. So let us have a few remarks around this, and let's get excited to talk about the issue of AI, but particularly equity and in the issue of healthcare services. So you can move to the next slide. So I saw this headline, AI heals the world. It was like, wow. If that will be possible, I think that will be the best thing that will ever happen for us in humanity. If AI could be the one that helps us heal this world, and there are all these big ambitions, you know, that AI can help us in early detection of any kind of ailment. You know, before you even know that you have cancer, AI tells you there's cancer coming, you know. Improve decision making in hospitals, help in treatment, expand. My slides have disappeared somehow.
Sure. In a bit, they'll be there.
Should have given me a warning. The AI should have warned us. Okay. Yes, yes. So all these issues around, you know, giving superior experiences, helping with end of life care. So there are all these beautiful and impactful, you know, applications of AI in the field of healthcare. Yeah. And if it's able to achieve all this, it will definitely heal the world. Okay, so let us think about it. What did it take for us to get here? Where every single person, every single individual is able to be reached and is able to access all these beautiful services that AI is offering. Yeah, all it takes that from every end of the world, we are able to access this kind of services. So let us imagine where AI is hitting the world. Okay, let's move to the next slide. So AI equity in healthcare. I saw these 6 principles of AI in healthcare, yeah? And one of them is to ensure equity. Among others, you know, promote human safety and well-being, ensure transparency, foster accountability. But our theme of today is really about equity. But what is this? What do you mean by equity? And equity normally goes with inclusion. So what is really equity and inclusion? Okay. It's about a sense of, as we think about developing AI systems, as we think about healthcare, are we aware of the diversity of needs that exist within the field of AI? Okay, are we catering for all those different diversity of needs that exist and require different kind of services? Think about wanting to build a very nice decision support system, okay? Will it serve some rural community that maybe don't have electricity, okay? How can we make the same system available to them, okay? Think about if you're to train a model, okay? Does your data set consider all the diversity and all the needs that exist within the society? That's the second point, diversity of data sources, yeah? Is it inclusive enough? Does it have all the different variations that exist across? Can we build, if not, can we build specialized versions of them that serve different communities? So at the end of the day, we have access and equity in all the different sectors. Are the stakeholders who are involved engaged? Okay, from every cadre. There's one time you are involved in a system development, okay, that required that data be entered at the point of service. When we went to the hospital to deploy, the only people at the point of service are the nurses, and they are saying their role is not to enter data in the system. So there was no one to enter data in the system. So are the stakeholders engaged? The system is there. They're saying them, they inject, they measure temperature, they not enter data. They need to be somebody called the data person who enters the data. So, you know, and that is how we couldn't deploy the system there. So are all the stakeholders engaged who are involved within this particular sector? Okay. And then when you think about the different AI developmental selections and use cases, have you thought about it so that you're able to be saying that for sure, as we come up with this AI technology, we have thought about issues of equity, we have thought about issues of inclusivity, and we are actually providing the AI across the different needs and across the different requirements. So next slide. Okay. So what is the main source of this lack of equity or lack of inclusivity in developing AI systems? And I think one of the areas that you have to think about is the idea of bias. I think if you are here, you might have heard the word bias a few times, so AI bias, okay? which is some kind of, some error, not really an obvious error, but some anomaly in terms of the AI system that is due to some prejudiced assumption. Not necessarily you might be aware of it or might not be aware of it. That can come up during the development or in the data processes. Okay, this is where the origin of this idea of equity comes in. You're actually cognizant of the idea of the bias that exists in AI and think about it as you develop the AI process. So there are different areas where bias can come in. Okay, there are real world patterns of inequality and discrimination that exists. Okay, so sometimes there could be some biases in the way the real world works. And if you collect data with these biases, of course, your AI will also model these real world biases. Are you cognizant of the fact of this existence of these inequalities or discrimination that exists? And as you build your AI, are you promoting these disparities, or are you trying to bridge the gap because of the real world patterns that actually exist? Okay, and think about bias in data. Okay, I think I've already mentioned that. Sampling, where is your sampling sizes coming from? Where is the representation coming from? Is your data set representative of all the different diversities that actually exist? Okay, and then these patterns of bias and discrimination, are they baked into your data distributions? Okay, and do you actually think about it? So that's why it's important to engage stakeholders and engage many people, because sometimes you might be really innocent and just building a very nice system that predicts, I don't know, pneumonia in chests of children. But apparently you only capture the chest of children from from the city and never from the village or something like that. So really you might not be aware that you're actually propagating some kind of inequality. And then there's some kind of application use cases that can also increase during the use, okay? And lastly, sometimes there are also applications of bias when it comes to the design, okay? So the bias AI designs and deployment practices, where you're talking about, for instance, are there some kind of power imbalances that exists wherever you're trying to deploy your different AI applications. So we have to be really, really cognizant. If we really want to achieve AI inequity, then all these different facets that exist in terms of equity aspects must be considered as we develop our AI systems. So let's move to the second last slide. Okay. And I like these 6 kind of ways to be able to help practitioners and businesses and policy leaders to think about a way forward for AI, okay? So that we really limit the idea of the bias that exists within the AI systems. So be aware of the context in which the AI help correct for this bias. Okay, and those in which there is a high risk for the AI to exacerbate the biases. Nowadays, I see that almost every call, if you apply for different calls for projects, they are very keen on, are you aware on the existing biases that can be able to come up? Okay, so I need second, established procedures, processes, and practices to test for and mitigate bias. That is really one kind of test that I don't think so many people overlook. And they only realize when somebody raises, like, hey, your system doesn't recognize this feature. And then you realize that maybe there was a bias in my data set, okay? Engage in fact-based conversations about potential biases in human decisions. That is the inherent bias in the society. So let us really have that opportunity to engage with different stakeholders and be able to really articulate what could be potential cases of bringing the idea of bias that will lead to inequality in the AI systems, particularly in the healthcare sector. So fully explore how humans and machines can best work together, invest more in bias research, make data available for research, and adopt a kind of multidisciplinary kind of approach. And then invest more in diversifying the AI field itself, which I think we are also doing here, and having this with conferences is a kind of way of diversifying the AI field. So I hope this different principles trigger some kind of thought in our minds that makes us aware that the idea of being cognizant and preparing for them and not just scraping the world and building a system without taking time and understanding your data and understanding the different diversities and understanding the potential risks that may arise due to the bias in your system or the bias in the AI model. So as we wind up, the last slide, I like this quote that I found online. Without critical digital infrastructure and standards, so AI-based products will actually go either unused or do more harm than good, and especially when it comes to AI in healthcare. So the idea is for us to be able to exploit the potential of AI to the maximum and actually achieve the level of equity that we have, then AI has to work, but not only work, it has to work for everyone. So unless it works and works for everyone, we have not achieved any level of equity. So as we open this research, let us discuss, let us contribute, let us hear the beautiful positions that are coming up front and think about how can we make AI work, but also AI work for everyone in AI in healthcare. So thank you so much for your time. And I welcome you all to this event. And I know we'll learn a lot and we'll share more, and wishing you all a beautiful day ahead. So thank you, Millicent, for that.
Wow, just wow. Thank you. Thank you very, very much, Dr. Lilian. Wonderful speech. Thank you for opening up the session with such a great presentation and motivation, right? It's our call, all of us in this room, to ensure that we build or we train equitable uh, um, AI technologies. And this starts from the data, just like you've mentioned, right? And we all know how we have data issues in our region. For us, we will just be fighting for our region, Kenya, and Kenya to the world, of course, right? So, Lilian, that was really great, inspiring, and thank you very, very much for starting us off. Yeah, I hope you'll stay for longer, but feel free to leave. Thank you very, very much,
Thank you
Dr.
too.
Lilian.
Thank you
Should we
too.
give her another round of applause?
Okay.
All right.
Thank you so much.
Okay. Thank you, Lily. All right. So I'll move very quickly to our next agenda. Uh, in a sec, be able to see the slides. Okay. Okay, so let me just talk a little bit about the goal. Thank you. Lilian just started us off, so let's start, right? So Women in Data Science, this is a regional event, and it is part of Women in Data Science event hosted in Stanford University, right? So these are events meant for with the goal with meant for like trying to accomplish these three goals, usually to inspire women to join the field of data science and AI. And not just inspiring, I mean, we want to support them because yes, somebody has motivated you, you've joined the field, and so what, right? We be there for one another and support one another in the field because there are so many technicalities in there. And then we also believe, sorry, but for some reasons, Teams doesn't like me today. It keeps logging me out. Yeah, I think so. But I'll just keep joining and resharing. So, um, yeah, so one sec. So to support women to join the field of data science. And we also believe that a data science community is not well represented until we are more inclusive, right? So a data science community is one that embraces diversity. And so we are here to educate everyone, regardless of gender, right? And so we share the common goals with WIDS worldwide, which is like our goal here regionally in Kenya, which is to build a community and strengthen the Women in Data Science Kenya community by inspiring our female data scientists, supporting them, and just ensuring that we educate everyone, and also like come together to network, to talk, and to just keep ourselves updated with the ever evolving field of data science and AI. So this is the brilliant team that was behind planning this event, and plus our previous events. We've had WiDS Datathon, and the team really worked so hard to just make sure that we put everything together. I'm sure some of you participated in WiDS Datathon, some didn't, but next year we will also come back with the same event, right? And then here we have our partners, right? So we also couldn't do this without Microsoft. They've been there to help us in whatever way. We just need a venue, and then they are there for us. One of our datathon sessions we hosted in University of Nairobi, and so we are very grateful for them as well. And then Microsoft Africa Research Institute, which is my organization now within Microsoft. We also have Microsoft Garage. I'm sure many of you who came who joined us in Datathon, Datathon. You met Lydia, our garage lead. She gave us quite an interesting talk as well. So welcome. Now, yes, Dr. Lilian mentioned it, but our theme for this year's conference is AI equity in healthcare, right? And she started herself, and I don't even want to repeat what she said. I might spoil. So yeah, here's how the program is scheduled look like. So we've had the opening remarks. I'm going to talk a little bit about. No, I don't think we will have time for that. But then I wanted to talk about the datathon and stuff, but that we don't have time. So we will have our keynote speech which will be delivered by Dr. Doris, and we will have our technical talk. After that, we'll have a small icebreaker. We will have Diana present a hands-on session. We will have some spotlight talks. These are night talks, short. We try to make these events not look like you just come and you listen. We wanted to incorporate some hands-on and to also showcase some of the amazing work that other people are doing in the field, right? So Mutanu is going to present to us what she's been working on, right? And also Dr. Nelly. And after that, we will have Dr. Wambui. We'll just dive deeper into the subject in the panel discussion session. And then we will just call it. Hey, so I'll just go ahead and introduce our keynote speaker. So we'll have Dr. Doris Machaki. She is an Aga Khan University Sonam lecturer. She held position at Aga Khan University, Hospital, Procter and Gamble PCA Kikuyu Hospital, and Nairobi Hospital, I think, before joining Aga Khan, right? She graduated from the University of Nairobi with Master of Science in Nursing, Oncology, and Bachelor of Science in Nursing. She belongs to the to both the Kenya Oncology Nursing Chapter and the Nursing Council of Kenya. In collaboration with NCI she has inspected oncology cancer facilitates around the nation and provided technical support to newly established cancer centers. She has worked with NCK, NCI-K, and NCCP on the new review and creation of several policies. She has contributed to the creation of oncology nursing diploma programs for numerous training facilities throughout the country. Please, let's welcome Dr. Doris, and as she comes, I'll be sharing the screen.
Thank you for that nice introduction. They have gotten a new couple, and despite it being in the pipeline, Millicent has decided to, bring it up earlier. I'm quite sure.
So I think the people won't be able to
Here.
Yeah.
Okay.
Before I'm here.
You can do it for me. So the first time I got the call to give a talk on health and equity from Samuel, I was like, okay, so equity. Then Samuel says specifically cancer. Like fine. Then I think we'll be biased towards oncology because that's my specialty. And when we talk about equity and cancer, we really need to bring out how basically our population can be able to access the cancer treatment, cancer diagnostics, cancer prevention in good time. Then we need to introduce AI. And how does AI make it easier, for our population in accessing health? So when we talk about women and health, and today being soft spoken. We are not used to things. Now it's better. Okay. Millicent, you can go to the next. So today is a very special day. It's International Women's Day. And the theme specifically is about investing in women and accelerates the progress. There is Miss Saima Wazid, who is the WHO County Director of South Asian. She said in her speech, investing in health and well-being of women and girls first requires adequate investment in health overall. Because remember, it starts from conception, okay? From conception till delivery and all through until we come grounded in our own known people, be it a woman or a gentleman, okay? So what does it mean when we talk about investing in health and the well-being of women? So I'll start off by giving just appreciation of the various women in health, more specifically in cancer, that have really done a brilliant job in ensuring that equity of cancer services have reached each and every one of us. So we have people like Nelly Nyaga, who is the head of NCCP. We have Tanya Akumu, who is the chairperson of the oncology chapter. We also have Zipporah Ali. We have Shahim Shaid. And we also have other several cancer survivors like Jane Kabaki and Koi Karua, who have really contributed well in ensuring the equity of cancer services throughout the country. Now, when we talk about the statistics of cancer in Kenya specifically, and more into women, we'll see that we have 28,377 new cases every year. And this is a data that was collected by GlobalCan by 2022 and published last year. And among this, you find that for you and me, we have a 17.4% risk of developing cancer by the age of 75. Okay. And this is, when you compare this to men, the incidence of cancer in men is 16,349. So you can be able to do the mathematics and do the difference. If men is at 16 and women is 28, what is the gap? Tell us we have a lot of work to do, right? On the mortality rate among the new cases or anybody diagnosed with cancer, we have 18,003 deaths. And 12.2% of people diagnosed with cancer have a risk of dying before the age of 75. So that calls us to act from prevention, to act from screening and diagnostics, from the treatment and rehabilitation. Now, in women also, when it comes to the leading cancers, we have cervical cancer, breast cancer, and esophageal cancers. And it's interesting because things to do with cervical cancer, they are preventative. Okay. Preventative through vaccination, preventative through early screening. Okay. And this is unfortunate. So we have a long way to go. Breast cancer, we can't be able to detect them early. We can't be able to look at the genetic markups of every woman. Okay. And we can be able to mitigate before the disease develops. So what are some of the challenges that women face in accessing health or cancer services? So we have one, the cost. If you look at majority of women who come during late diagnostics, they come from which regions of the country? From which regions? The rural regions, okay? So them, by the time they're accessing these services, it's late. They'll say, I don't have money for transport. I don't have money for the test that will be required for me to do. I don't have someone to take care of my children so that I can be able to go to seek health services, okay? So we have cost implication in all this. Secondly, we have health literacy, okay? If we ask how many women can be able to access information about the various cancers available, there are very few, okay? Some, it can go to the extent of not really understanding the materials that they are reading or the information that they are being given. So we do have work in terms of the health literacy. The health-seeking behavior is another aspect. But how? If I can ask in this group and even the people on the virtually, for women, how many women above the age of 18 have ever gone for pap smear? How many? Millicent, you can do the calculation. But there are very few. And the reasons behind it, there's fear of the unknown. How many have ever gone for clinical breast exam? That the number even goes down. For cervical cancer, it's even bigger number. For breast cancer, breast exam is even lower. So we have that. If you are asked, why don't you? Do you really have a concrete reason behind it? Well, that's a question for you, don't answer. So there is that. Then we also have accessibility to these services. Where, if you look at the county you come from, you're Ushago. Nairobi is not Ushago, right? Unless for those people who are born around. Your own facility at home, the health center facility, what are some of the cancer services that you can be able to access? Which one? The clinical breast exam? I can see people shaking their heads. So accessibility of these services is also a problem. Majority of them are concentrated in the cities, right? Then we have poor clinician to patient communication. You come, the mother is there, or any young woman is there, wants to get cancer services. And then you go ahead and ask, why should I do these services? Do you receive adequate information as to the why? Once the results come, is the results explained to you in a manner that you can be able to understand? We'll tell you you need to have, maybe you did a breast ultrasound. You need to go and do a breast mammogram. Do we tell you the reasons behind it? When you come for maybe a biopsy, do we tell you the reasons behind you needed to do a biopsy? Or you have said, me, I was sent to go to the lab. I don't know which test. I don't know why, right? So poor clinician to patient communication is still a problem. Or you might find maybe, that hospital, where the doctors, the nurses, they treat us badly. I'm not going there back. So we need also to improve on that. So when we talk about the gender disparities in cancer care, we have early detection as one of them. What do I mean by early detection? Majority of us as women will have a problem. We'll go and tell our friends, do you know, one of my breasts has been having issues. Huh? It is very tender. It's not even near that time of the month. Huh? Then your friend will be like, you go be seen. I will go, but not now. Not now. We keep on postponing. Oh, I don't have time to go. It's the month of, majority of us look at the month of October. That's when we go and do all the check. And February, it was here. It was Cancer World Month. On 4th, we celebrated. But that whole month, majority of the health facilities, they were doing free checkups. Others were doing subsidized prices for, be it mammogram, be it ultrasound for the breast, be it pap smear. But how many of us took that opportunity to go for testing? We'll say, there's another one in October. But unfortunately for some of these malignancies, time is advantageous to them because what they're doing is they're multiplying. So if we say in October, the growth maybe would have been seen at maybe 1 centimeter. By the time it's October, it's probably 3, 4. Okay. Then we have access to quality healthcare, which we had already talked earlier. It's the same concept. Okay. We have participation in clinical trials. Majority of this, you'll find that the clinical trials that are going on, yes, some of the cancers affect cross-section, but you'll find majority of the people who will be enrolled in the clinical trials are men. Okay, so we need also to include women. Reason behind it is because of our genetic makeups, variation that are in. We are talking about data, having data, developing algorithms. So we need to develop algorithms that will also benefit the women population. Awareness, only a small percentage is still aware of the various cancers. So we need to go into the grassroots, okay? And when we talk about technology and how we can be able to reference on that, we have various apps that tend to tell you on what to check for. There are apps for education, to educate us and women and everybody at the grassroots. But also we'll need also infrastructure so that we can be able to infiltrate into the grassroots. Then we have education. When you look at in education, who is favored? Yeah? The boy child, right? If you look at the latest KCSC that was just announced in January, you can be able to see the disparities between the two groups. The men or the boys are more compared to the girls. Why? Unfortunately, still culture, the society plays a key role in this. So until we can be able to say, stand up for the girl child, ensure, even if Kamani, I will not want to touch specific communities, but you all know, right? The boy child is the pillar of the home. So we need to educate the boy child. But what happens if you educate the girl child? The community grows, right? When you look at employment, big positions come up with good incentives, right? Good medical covers. But now, who are the top? Male dominated, okay? So for us, women will be like, okay, fine, I have that medical cover. Do I go for pap smear? And I have no problem, I have nothing, I've not experienced any issue? Or do I keep that medical cover for the child? What do I do? So we need to ensure we encourage our women to apply for those top positions. Let's not shy off, okay? So what are some of the strides that we are trying as a country to bridge the gap and ensure that women, and not only women, but everybody in our community can be able to access cancer services? So we have one, decentralization of the cancer services. And you'll find that if you do a baseline investigation and just establish how many centers and in how many counties, we have 28 cancer centers, both private and public, in 28 counties. So 28 counties, we have cancer centers, okay? So we have how many counties? 40? 47, so 28, 47 minus 28? 19. So only 19 counties haven't been represented. So we can assume if we are in Kiambu County and Nairobi County, so probably people in Kiambu can be able to access healthcare in Nairobi, okay? So that one gives a upper hand in terms of decentralization of cancer centers. Now, when we talk about cancer centers in terms of private and public, we base them in different categories. We have 3 categories that we are able to classify them in. We have a basic cancer center, whereby you can only get maybe 1 or 2 services. For example, you can get a preventive or a screening service and 1 type of treatment. Okay? And majority of the time, you'll find majority of these primary or basic cancer centers, they provide chemotherapy treatments. Then we have middle level cancer centers. And in middle level, they provide 2 types of treatments, modalities. So it can be either chemotherapy and radiation or chemotherapy and surgery. Then we have comprehensive cancer centers. And in comprehensive, what is topped up is they have 3 major treatment modalities, or 4 major, that is radiation, they have chemotherapy, they have surgery, and then they can put on the hormonal ones. And then from this, then on top, they have a school that educates nurses, doctors, clinical medicine people on cancer diagnosis and treatment. So from the comprehensive centers that we have in Kenya, we have MTRH, we have Kenyatta, we have Jaramogi. Those are some of the public centers. For that, we have KUTTRH. For private centers, we have Nairobi Hospital, we have Kenyatta, Aga Khan University. Which other one? And there's one that is coming up, Nairobi West, that will be also be comprehensive. So that means we are making strides towards cancer treatment and ensuring that it's equitable. People can be able to access. We have creating of awareness. And in creation of awareness, the ministry has come up with a communication policy that was released last year. And what we are trying to do is to ensure that the information that is out there is the same, okay? So that we can try to avoid miscommunication or misrepresentation of information. A step further is that they've ensured they've translated some of these materials in several languages. So if it's a Maasai, they can be able to get the information. If it's Kisii, they can be able to get the information so that no one will say, I'm illiterate, I don't know how to read, but someone else can be able to read for you the information in your own language. We also have outreach programs stemming from the preventive measures, whereby we are doing the screenings, we are doing cervical screenings, even in the remote areas. Okay, and this one has enabled us to access each and every person. Even if you are a pastoralist, we can be able to get you. We also have capacity building of health personnel. And we are trying really very much in training nurses, training doctors, training clinical officers, training pathologists on cancer treatment. Okay, even a pharmacist. We also have NHIF stroke, the Social Health Insurance Fund uptake. So nowadays, what we are trying to do is encouraging everyone to register for that. Okay. The reason behind this is because NHIF or the Social Health Insurance Fund is paying for the treatment. Okay. That makes or that lifts up the burden of finances on the cancer patient. We also have leveraging in technology and whereby AI is coming in. How do we do that? Despite us having the apps, or apart from having the apps whereby you can be able to access information, we also have platforms whereby healthcare personnel can be able to access training materials. We also have technology in diagnostics. When people go down to the remote areas and collect samples, they're able to send the samples, the videos and the photos of those samples. And the technical people in Nairobi can be able to analyze and give feedback to the patient and the doctors in good time. So what AI and what the technology is doing is shortening the turnaround time for our patients. So how do we apply AI in healthcare or in cancer? One, in improved healthcare access. So if you can be able to access information or data about a patient, we can be able to act quickly. And we are thankful for COVID. You know, sometimes we say COVID came with so many things, huh? But we are thankful for COVID because COVID taught us you don't need to be where the patient is. Okay. All the information about that patient can be collected by someone who is on the ground and shared. What we use telemedicine, analyze, discuss about that patient and come up with a plan of action. So it is making the people even in Moyale be able to access health care services. Effective administration processes. We said data. With kiddies, data. Women in data. Data in health. When we key in the data in health, we can be able to link it. So what we are doing is every information about a patient, be it in Garissa, every month we are able to get all that data. And we are not going there physically. We have systems that have been linked, okay? It is also helping in the human resource aspect. You can be able to plan for the patients and see, so we have so many patients on this date, we need to work around that so that we are not overwhelmed. So it is helping in the administrative processes too. Precision medicine is what we call where a person or your data is taken, we are analyzed, and we are able to come up with the best treatment or management for you. So we tailor make that treatment suited for Doris. And Millicent, unfortunately, you cannot use it. Huh? So we'll take your data and tailor make a treatment plan for you. So that is what we call precision medicine. We have applied it in so many ways, even when you come with what we call targeted therapies, they use that. We also enhance diagnostic accuracy, but this can only be made with the data that we key in. Okay, remember Dr. Lilian talked about bias. So for the accuracy to be better, we need to ensure that the information we give is good. When you talk about enhance, we can be able to get the slides, upload them. Someone will be able to analyze, and then we can be able to give you an accurate data because also the algorithms are already in place. Okay. We also look at language and cultural access. So we talked about communication and how we are trying to tailor make the reading materials in languages which our patients can be able to understand. So for example, if the literature is in English, we have softwares that translate that material into Kisii, into Embu, into Kikuyu, right? So the patient is able to get accurate information and in a language that they can be able to understand. So I'll just, at that point, I would really love to appreciate all the women that are in technology and women that are really helping us as the care providers be able to do our work seamlessly. Thank you. Also, we have personalized health education materials. For example, if a patient is coming in and the patient has maybe cancer of the breast and they're receiving a different treatment regime, they can be able to be tailor-made a health education for that. That is different from someone else who will get in a different treatment regime. So you have personalized health education. We have also enabling remote monitoring of patients, whereby you can just virtually or they can key in information in an app and they can be able to communicate with the doctors or the clinicians on the other side. We also have reducing bias in clinical decision. And this can only be helped if we key in the correct information so that the system can generate algorithms that have good and also can be able to reduce that bias. When we talk about bias in clinical decision making, for example, when you look at patients, maybe they have leukemias and we want to treat them, we have different protocols. So by streamlining the protocols will enable removing that bias. Then we have predictive analysis of preventive. So you key in your information, it will tell us, are you at risk or not? If you're at risk, we can be able to do something to mitigate before the disease develops. So it's important for us and everyone to come together so that we can be able to work in teams. We are told if you want to go far, don't walk alone, okay? So we need to partnership, we need collaboration. Collaboration and partnership from the healthcare perspective, from the technical people or people in tech, from the research institutes, from various institutes so that we can be able to work together. And these collaborations will help us reduce bias in the technology that we are going to develop. We are going to enable us in ensuring that all patients are catered for in good time. They'll enable us to ensure that we remove any ethical problems or things that may hinder us from achieving our overall goals. Supportive and initiative that promote women participation in tech, AI, and health organization is important. If we don't support women, then what will happen to our community? So let us support women participation. Then also policies that address gender disparities need to be made. We need to put in place policies that will encourage women to participate most, and in the process we can be able to remove the gender disparities. So in conclusion, investing in women will accelerate the progress in bridging the gap in cancer care, and also involving women in the creation of awareness about women's health and technology and cancer. We also need to create a future where women have equal opportunities to contribute and benefit from the advancement in AI and in health. There is no limit to what women can accomplish. So let's join hands together. Thank you.
Wonderful speech. And that's not we're just getting started. Dr. Doris, quite informative. Thank you very, very much for inspiring us with your great presentation. We will have to clap for Dr. Doris one more time because that was quite insightful. Thank you very much, Daktari, and we'll move forward. Do we actually have questions? I'm reminded that in case, yeah. Do we have questions for Dr. Doris before I proceed? Yes.
Yes, I do have.
Yes.
Thank you for your presentation. My question is around something you touched on, health facilities collecting data. So my question is directly on the shareability of that data, because you find that the data is there within one hospital. Is it accessible to other health facilities or even the healthcare spectrum? And lastly, if I'm an independent researcher, am I able to get access to that data?
That's a very good question. One, there are various things that will have to take place by the time you're accessing that data. So for cancer services, all the information is usually relayed to our cancer registry, which the head is NCI Kenya. They're the custodians of that data. So for you to be able to access that data, you have to go through them. And they have to go through, you have to show the purpose of that data. Why do you want that data? For what reason do you want that data? So you have to write to them, and then they'll be able to sit down in the board and decide whether does your request meet the merit, okay? So that the data can be given to you. Yeah. From the health center point of view, will also depend on the purpose of that data. So if it's for research purposes, you have to go through the ethical approval process. Then you have to get an acoustic permit. Okay, the reason behind this is just to be able to see if we can be able to ensure there are no loopholes for you accessing that data. Okay, so that if you go and publish that data, you have the ethical backings. And the ethics will go through the vigorous process to ensure that you've ensured the confidentiality, the ethical processes that needed to be in place, you've put them, so that you don't go and just, share patients' information. If there are any identifiers, we ensure that no identifiers will come from that particular center that you want to get the information from. Yes. Thank you.
Any other question for Daktari? Any other question? Or are there questions online? Those joining us virtually, do you have questions for Daktari? Guess not.
There's a comment here.
Sorry, what? No, it was just a confirming that they can hear us.
No, there was
Oh, got it. So I have a similar okay, so let me just read loud. I have a similar challenge on accessing data. I'm working on a project on prediction, I think of healthcare with terminologies. Prediction, okay, you know what's that?
So the
Condition among pregnant women.
Yeah, so one of the participants is asking, I have a similar question on access of data. I'm working on a project on prediction of preeclampsia condition among pregnant women. Yeah, the same case applies. If they're not giving you the data, then probably you don't have ethical approval. So you need those documents and getting a costly permit so that the institution. There are several steps. For example, in Nairobi County, you have to go through the county health office for them to see that you have the ethical approval, you have an acoustic permit, and then for them to give you authorization letter that you'll take to the specific health facility that you want to access data from. So there are several steps by the time you are getting or you're accessing that information from that particular center. All this is geared towards protecting our patients' information. Thank you.
On the process, how friendly is it, or how easy is it to go through the process so that you can get data? And do you think that the process is one of the challenges that probably is experienced when you're trying to bring in AI and predictive analytics into healthcare? Because now for such a project, I think it's going to be very helpful. But now if the process is very tedious, very hard, then isn't it
Can give up.
a challenge, and you're then hindering the development of healthcare in Kenya?
Partly yes, partly no.
Okay.
We all know about our processes in Kenya, especially the public sector. The turnaround time is a little bit, humongous. And I'll give an example. For example, if I was to do a study in Kenyatta National Hospital, the minimum turnaround time for ethical approval is 3 months. So the question is, am I patient enough to wait for that? And I know the information or the data I'm going to get from that facility will be rich because of the diverse of people. So am I patient enough? Or will that hinder me and say, you know what, I'm going to file it? So it all depends. Yes.
I think we will have to move forward, right, guys? Because I'm really sorry, but we will have to move forward because of time. So let's move to our technical talk. This is going to be really delivered by Ms. Tanya Akumu. She's currently developing research in exploring trustworthy AI concepts such as bias, uncertainty, quantification, robustness, explainability, and causality, and anomalous pattern detection techniques. I think Tanya is going to help us understand more. So let's give Tanya the platform. Over to you, Miss Tanya.
No, I can just stand. Hello, everyone. I hope I'm audible enough. So as Millicent has said, today I will be, first of all, I'm Tanya Akumu. I am a research engineer at IBM Research in Research Africa. It's located here in Nairobi at the Catholic University. And today I would like to talk to you about explainable AI in healthcare. You've heard Dr. Doris and Dr. Lilian talk about AI being used for decision making in healthcare. And when we cannot understand the cause of these decisions, then that becomes a problem. And that's where explainable AI comes in. We need to be able to explain these decisions that the model is making for whatever application that we are using it for. But before I start, I would like to introduce my team. I work with an amazing team of super smart research scientists. Some are from different countries, but we're all based here in Nairobi. So in this talk, I'm going to give you some background and motivation of why explainable AI. And at the end, I'm really excited to walk you through some implementation in a real world application. So if you are a human living in the 21st century, you've probably heard about AI, especially since the release of ChatGPT. I don't think there's anyone in this room, whether you're a doctor, a nurse, a secretary, you've had AI somewhere. And currently, oh, sorry. All right, sorry about missing the slide. Right, so as I was saying, we are in the age of AI. And this is a period of unprecedented innovation that is changing not just the way we work, but how we interact and how we solve these grand challenges. AI has transformed our daily lives. It has transformed economies and industries, and we've also seen it how it's transforming AI. And just to emphasize on AI in healthcare in terms of the different applications, if we go back 50 years, the idea of using computers in medicine was like science fiction. But then today, in this AI revolution, we see that the healthcare industry is being transformed from, predicting early detection of diseases like breast cancer, as Dr. Doris had alluded earlier, to even optimization of delivery routes for medical supplies and vaccines so that we can get these to remote areas, rural areas in the best cost-effective way. So AI's role in healthcare is undeniable, and it has a huge potential to improve patient outcome. It has a huge potential to improve healthcare systems, and especially in resource-limited settings like ours here in Kenya. But then, sorry, what's going on? Okay, but with great power comes great responsibility. There exists a critical problem with integrating AI into decision-making applications due to what we call the black box problem. The black box problem refers to, in machine learning language, refers to the lack of transparency and interpretability in AI algorithms. We know what goes into the model. We can see the data. We can see what gets out, that's a decision, but what goes on inside, how does it come to its decisions? For example, and first, because we don't know this, we don't know how it comes to these decisions, the consequences of wrong decisions or right decisions for the wrong reasons can be very severe, especially in critical sectors like healthcare. For example, it can misdiagnose or provide an inappropriate treatment plan in the personalized medicine application that then could cause harm to the patient or might even delay necessary care. As we saw earlier, time is of the essence for some of these diseases. We know that these AI models can amplify the bias that exists in the training data, which can then lead to unequal care or discrimination for certain groups. An example, actually, there was a study that was published in 2019 that found an AI model that was being deployed in public health in America. This AI model was supposed to identify patients for high-risk care management, and it became racially biased because it used cost as a proxy for health. But Black people are not able to afford healthcare. But because the model is associating cost, it says because Black people don't pay for healthcare, they're healthier than white people. So if you're Black, I don't recommend you for further treatment. And that became a problem. And if you're deploying this in a real world application, we do not want to discriminate against some groups, especially in such a critical situation of life and death. So therefore, it is imperative that we understand how they make these decisions. We want to move from this glass box problem to a glass box where we can explain or interpret the output of these models. And that's where the term interpretability or explainability comes in. So usually they're used interchangeably in the ML or AI community. You'll hear people say explainability, others will say interpretability. But regardless, Tim Miller helps us to define interpretability as the degree to which a human, not a model, a human can understand the cause of a decision. The model has given me a decision. Can I understand it? Can I understand the cause for that decision? And interpretability means that we can trust that the model is predicting an output for the right reasons. In the other case, it was predicting an output, but for the wrong reasons. You're Black, you're healthy, but it's because you actually don't access the healthcare, not because you're healthy, but because you're poor. Right? So we should be able to trust that the model is predicting an output for the right reasons. And this is important because the models making these decisions are only as good as the insights it gives on the problem at hand. If the output is not meaningful, if it cannot make sense of it, then we cannot really use it in an application. Furthermore, the GDPR, which is the General Data Protection Regulations that the European Commission came up with, it stipulates the right to explanation over an individual's data. And these models are trained on individuals' data. Therefore, we should be able to adhere to this requirement. In some cases, as we've seen before, being able to interpret model outputs can help us to easily detect bias. For example, if we find that model is using gender to recommend job applications, and it says because you're a woman, this job is male dominated, you don't pass through. Or even for loan applications, it uses race as a proxy for credit, assigning credit risk. So because of that, maybe for those groups that are known to be marginalized, they don't end up having access to some of these critical benefits that would better their lives in future. So interpretability itself can help us to ensure trust. It can help us to ensure social acceptance of the AI's applications that we are trying to get people to use. So in terms of the scope of interpretability, it spans the local and the global context. In the global sense, we want to understand how the complete model works without looking at individual output. How does it work? Which features overall does contribute to the model output? But then we also have the local sense, where we want to understand how a single decision was reached. For Miss Tanya, she has a risk of cancer for 17.4%. What factors in Tanya are making her to get this risk of 17%? But how do we assess the interpretability of these AI models? So there are several model agnostic techniques that have been developed. One of them is what we call SHAP, or rather shapely additive explanations, which is an algorithm that checks for the global and local influence of the features using SHAP values. I'll get into that later. And then we also have other algorithms like the LIME, which is the local interpretable model agnostic explanations that uses simple surrogate models to explain local explanations. And finally, we have what we call the partial dependence plots, PDP, which assess the marginal impact of a feature on the model output while holding the other features constant. So if you have, it holds like your age constant and changes the others, and then see how the model output changes. But for our demo later, we will be using the SHARP algorithm. So let's dive a little bit into it. So this technique computes the feature contribution to the final model output using a cooperative game theory approach. So imagine you have a team working together to win the game. And after the game, the coach wants to assess which player had the most impact on the output. Usually, see, I don't watch football, but I usually just see people complaining, I don't know, Ronaldo has done what, he didn't. But, they are looking at specific players and how they contributed to the final output. So SHARP also does the same thing. It evaluates each feature in the data set. In this case, each feature is a player. The game is the task at hand, whether it wants to predict cancer risk or it wants to predict another type of disease. And then it contributes. Now, it gives us precise measurements on, for each feature in the data set, how much did it contribute? And it does this using SHARP values. And so I will explain what these SHARP values are. But basically, they are values that quantify the impact of each feature in the model's output. So if you get a positive SHARP value, it indicates that the feature has pushed the model to a higher risk prediction, or positive model output is high. A negative SHARP value, model output is low. And in this example setting, we have three features in the form of the three robots, one red, one blue, and one green. Each robot by itself has its own contribution, which is what we see on the left. Okay, you can see my mouse on the left. So each robot has its own contribution. However, when we combine them, you see the amount of coins for each robot. When we do various combinations, we end up seeing that sometimes some different combinations have more coins than others, depending on the combinations that's there. So what the SHARP value does is it averages the contribution of each player. So it takes this contribution, it takes into account these also the combinations when this feature is combined with blue, and when red is combined with blue and green, or green alone, or any other combinations that are possible. And it computes the average contribution in that. And that now gives us a precise measurement of how much the feature influenced the output. So now that we've had some founding principles of interpretability in AI, let's get to the fun part. This is where we implement in a real world data set, and I'm going to walk you through it. So we have an open sourced data set. And in fact, if you want to use this data set, you can just go to that link and it will allow you to download it and work on it. This is the Halsey data, which is a survey that was done on 5,000 individuals in a place called Agincourt in South Africa. So this is real data. And it has information or features on demographic data, things like age, like sex. It has information on clinical measurements, like some blood pressure measurements, blood glucose. It has information on lifestyle, how people, whether you drink or smoke or physical activity, whether you work out, and other information on chronic illness health. So whether you have diabetes, hypertension, HIV, it has all that. So in this hypothetical study, we want to predict the risk of diabetes. So because we have data on demographic, clinical measurements, we want, when we get that data, can we tell an individual whether they are at risk of getting diabetes or not? So this becomes a binary classification, whereby the presence of diabetes is positive, that is 1, and the absence of diabetes is 0. And in this data set, 9.1% of the individuals in the data have diabetes. So what questions are we trying to answer from this data? One is we are trying to find out whether we can develop an explainable machine learning model to effectively predict diabetes risk. And 2, what are the key risk factors that this model identifies as significant when giving an individual a certain risk? So we'll start with training the model. We first separate the features and the target variables. And in this case, we're using 80% of the data to train the model and 20% to validate the model on unseen data. And then afterwards, we train a tree-based classifier and we evaluate the performance using what we call the AUC, the area under the curve. And we see that our model performs quite well with an AUC of 0.9. And this is not like, don't ask about the different models that we could have used. That's not part of the scope of the talk. The scope of the talk is, once you get the best performing model, how do you explain the predictions exactly? So when we get our best performing model, then we introduce SHARP, and we are going to use the SHARP Python package. We create a SHARP object based on the best performing model. That's the model we just trained. And then we use it to compute the SHARP values. So it's all very easy, just 2 lines of code and you have your explanations. So what are the results? Let me walk you through some of the results from the summary of the SHARP values. So this is in that data set. This plot summarizes the order and degree of influence of the features. So the x-axis here is the average magnitude of change in the output when the feature is perturbed or the feature is changed or hidden from the model. So, and it's in ascending order. So when we change the blood glucose, we can see that the model output changes quite highly. So it means blood glucose was a very strong predictor for diabetes. And I'm not a domain expert, but the doctors in the room can be able to confirm that, if your blood glucose is high, of course, you're definitely leaning on diabetes, and the model has learned that. And so we can be able to trust that the model is actually learning what happens in the real world application. Then we also have hypertension as the second most strong predictor, which is kind of telling us that there could be a relationship between hypertension and diabetes. And if you're in the public health space, we know that there are these diseases that are usually co-occurring. Usually, if you're diabetic, your chances of being hypertensive is very high, and vice versa. If you're hypertensive, your chances of developing diabetes is quite high. And we can see that the model has learned that relationship as well, because a history of hypertension becomes an important predictor. And then we have waist hip ratio and blood pressure that are also among the top. Of course, if you have a larger body mass, it's not healthy to be that big. And we can see that the model has learned that. But then what happens when you want to look at the individuals in the whole data set, still in this hierarchy of feature importance? And so we can visualize the same plot, but this time for every individual in the data set. So in this graph that we've plotted from the sharp values, we have a dot. You can see the dots here, right? We have blue dots, red dots. Each dot in this graph is an individual in the data set. The X position of the dot here now is the impact of that feature on the model's prediction for that specific individual. So for these individuals on this side, we can see because first, and then also red dots means that the values are higher, like in terms of magnitude, high actual feature values, and the blue dots is low feature values, and then the purple dots are in between the middle. So this time you can see that for blood glucose, higher levels or higher measurements of blood glucose drove the model to assign these individuals higher risk, while lower blood glucose measurements made the model to reduce the risk. So before we were only seeing that blood glucose is a very strong predictor, but now we see that if we see it in terms of high levels of blood glucose drive your risk high, low levels drive your risk low. And we can see the same for hypertension. A 0, which is absence of hypertension, is the blue section. It drives your risk low, while a red goes to the positive side of the x-axis, means it drives your risk high. But then we can also go to a specific individual. And in this, we have two charts. This, for the first individual, the top graph, the model gave them a high risk of diabetes. And the bottom, they had a low risk. So from this graph, you can see we have their specific measurements. Like this individual had a blood glucose of 22.3. They didn't have hypertension, and we see red and blue. So if you see red, it means that that value drove the model to predict a high outcome, which is diabetes. You have diabetes. And for blue values, it drove the prediction lower, meaning it tried to make the model to lower the risk. And then we see that there's like a bar. This is a very large bar. This is a small bar. We have bars here. For each feature has a bar, and each bar has its own different length. So the length of each bar is the magnitude of the influence. So you can see for the feature, for the individual that had diabetes, the bar length for blood glucose was quite high, meaning this is what the model used to give them a diabetes risk. Hypertension, absence of hypertension, tried to, had a small strength to try to drive it lower, but of course, blood glucose won the game here. And then for this individual that did not have diabetes, we see that because they didn't have hypertension, that was like the one that had stronger influence on the output, and their BMI was quite low at 21.6. Like, they are not obese or overweight. So that contributed for the model to have give it a low outcome. But then we also had some critical measurements of total cholesterol being 4.3, and they were old age 93. That was trying to tell the model, no, they should, there could be a risk assigned there. So that is the end of this epic journey that we have gone. We have seen that it is important that we understand how these AI systems come up with their decisions, especially in sensitive applications like healthcare. And having explainable systems, first, it's not just a requirement, by law, regulatory requirements require this, but it also helps us to build trust and to socially accept the use of these systems. We also implemented model agnostic algorithms like SHARP that helped us to interpret the predicted risk of some disease, and we got some interesting insights on that. Now, once we know how the model comes to its output, we can now reformulate algorithms either to perform better, or we can do some actions, for example, like only focus on the features that are relevant for the model and remove what is not relevant. And this helps us, for example, in data privacy, whereby, okay, we've seen education is not really necessary, so we don't need to collect that data. And so it helps us with data privacy and using only what we need. So I implore you to apply this algorithm. I didn't write it. I've linked all the resources there. I've just used it for my work. So I implore you to try it in your own applications, in your own problems, and yeah, see the cool things that you'll find. Thank you for your attention, and yeah, I hope you enjoyed it.
That was a wonderful technical talk by our very own Tanya. Ms. Tanya, thank you very much. Quite insightful. I love interpretability. We all know how machine learning models or AI models can be black box, but then when us who train these models, we are able to explain them, it is a wonderful thing. Like, people will believe us, right? Because a lot of people don't. This was quite insightful, and thank you so much. Another round of applause, please. So we'll accept like 2 questions. Yeah, Terry, and let's just take 2 questions, because guys, we might sleep here.
Also going to be here after.
Yes.
We can come and chat after.
Yeah, so let's take one from Terry. The people online, please post one, or just feel free to unmute yourself, come on mute, and then ask. So we'll take from Terry. I think we should do one. Do we have a gentleman in the house with a question? I think we'll do Terry and Brian, right? And then you will ask during the okay, Terry, go.
Hi, Tanya. That's a very beautiful presentation. My question is, so how is then interpretability integrated to the user interface, especially for models that are related to healthcare professionals? Because as much as, yes, I'm able to understand the technicalities of what you presented, I don't think it's very explainable to most healthcare professionals, like all those bars and everything. Or is it just used for development such that then it doesn't, you just ensure that the model you have released to the professional at the end of the day is has already passed those explainability and the model is well functioned. Yeah.
Okay, so I would say both, right? Before you release the model, you need to make sure that it's interpretable, it's explainable, and we can understand why it's making the output it is making. And then at the user level, users here being maybe doctors, or maybe someone might even just put an app and ask you, if you know your measurements, just put it down. They still need to know. They have a right of explanation. So it's upon you, to the developer. Yes, you can show the graphs, and you didn't see this graph before. I explained to you what this graph was, and for that you were able to get some understanding. But then, that's where you collaborate with more UI experts in terms of what would resonate, or how the user would be able to understand the output of the model. But it should be that whenever the user asks, or even if a nurse the nurse is using an algorithm to either say, okay, this person has hypertension, let's screen them for diabetes. If the nurse asks why, the application should be able to say it. So you, as the developer, you have to put that into natural language, or into a way that the user can understand. But at the end of the day, is both the developer and the user is able to understand why the output is given.
comes in handy to build that trust and also goes a long way with regard to counterfactual explanations. So I just want to understand whether there are regulatory frameworks or institutions to audit such kind of things and ensure actually whatever outputs we are getting are up to standard. Are there such kind of frameworks?
I did mention before the GDPR, which is kind of a policy framework that is applied worldwide. So if you're, for example, if you are releasing an application in Europe, you have to follow that framework. You have to give whether right to explanation, you have to give the user the power to access, to recall their data if they don't want to, and all that. In Kenya, we do have some AI policies being drafted up. It's still in the works. I also know the Africa Union is coming up with a regulatory framework for African centers. And there are also some research institutes like the National Institute of Health in the US is supporting a lot of these protocols and policies that should guide research work that is coming out then to be to bleed into the user application. There's also the AI Alliance. You know, when the GPT was released, there's this AI Alliance of these big tech companies, Microsoft, IBM, Facebook joined, and they are together forming a protocol of how AI systems should be released and the different protocols or security measures that should be taken to ensure that we can be able to meaningfully use the output. So a lot of people are looking into AI governance. A lot of applications are being released with AI governance included. And yeah, I think from even in research and in real world applications, we will be able to see a bit of that.
Seemingly in Kenya, we are not there yet, but then a global spectrum point of view. Now, besides those frameworks being players, and then there's that enforcement office, are there like bodies who like sort of bodies to ensure there's actual compliance with those frameworks?
Yeah, first, I don't know about Kenya, but of course we have KEBS. If you are, there's KEBS that does the manufacturing stuff, but there's also talks. This is just from my basic knowledge. I don't really work in the governance or policy area, but yeah, there are bodies that are coming up that are vetting the applications or AI-based applications. It's mostly well established in Europe and in the US, whereby each application you release, if it uses user data, as long as it's using user data, you need to be able to provide proof of how the data is used, how decisions are made, and all that. We also have the FDA in the US. They also check all the devices or applications that are going out to be released. For you to get the license to sell your product, that you need to provide proof of all these tests and all these requirements, that you're meeting all the requirements in the protocols. In Africa, we are still not there yet, as you've mentioned, but we are getting there slowly.
Can I just add something about Kenya? So we have the Data Protection Act, and right now it's reactive. So if I know my data is being used by a third party, I have a right to complain and they'll investigate my complaint, and usually action will be taken. So we're not at the place where they'll vet every single application, but at least with the protection of data. And I've been working in a research organization, so we are required to uphold the Data Protection Act. There's no one to come and check that we're doing it, but if there's a complaint, then there's a framework that, within which we will be held accountable. So I think, at least there's some progress. Yeah.
Okay, thank you. Thank you.
Thank you very much. I know we have burning questions. Is it burning? Like times 3?
I wanted to clarify on the data protection part on section 4, chapter 35. We have automated decision making that is able to protect the data subject from automated decisions that are made concerning the person. So that touches on the algorithm and everything. So as already everybody has said, we do not have a single AI policy that is able to cover us completely on that. But currently, the Office of the Data Protection is able to maybe make sure that we don't have people who are oppressed using these automated decision-making processes.
So, thank you very much for adding that. Thank you. Our next presenter is Miss Diana. I mean, we haven't even stretched, but we are stretching in a bit. Let's have Diana. She is an associate data scientist working to link machine learning and healthcare. She's also taking her Master's of Science. Yeah, she's an MSc student at the University of Liverpool, looking forward to contributing to research and publication. So before WiDS conference, we do host WiDS Datathon, and I believe most of us participated in these datathons. Participated in the datathon, but we had workshops to prepare our participants for to participate in the challenge that was being worked on Kaggle platform. So Diana is just going to walk us through what we needed to have done, and it is quite an interesting problem in healthcare, and we needed to see this because this is one way to support people with the hands-on skills. Diana is going to talk more about the problem. Thank you. Just share.
All right. So hi everyone. I won't take much time, not even 20. I'll just go through it over the notebook with 10 minutes because we've had a whole 2 months of looking at the datathon problem. And I kind of want to have that space of the panel and the spotlight happening because I'm really enjoying, and this is something we've been doing for 2 months. So I'll just rush over a sample solution, touch here and there. So as she's opening it up, maybe the problem for this year was with breast cancer. So we had a data set from Gilead Sciences, which is a bioscience pharmaceutical company. It is white. Oh, I've never seen a notebook that's white. Yeah, so but it's fine. I hope I'll get used to it. Dark mode. But anyway, so basically the data set was from Gilead Sciences, which was the sponsor of this year's WiDS Datathon. So the data set was super rich, and this is why there's that question from this side. So the US has done an amazing job in terms of de-anonymizing data and publishing it for us to do such kind of items, right? And they have so much granularity in their data, as you'll get to see what we have today. So the challenge was basically predicting the patient, if a patient received diagnosis within 90 days of screening. So there are the stages of that you go through, which I think Dr. Terry and Dr. Terry and Dr. Wambui, right, took us through the last time. So these processes of screening, diagnosis, up to treatment. So how does that look like? So what we'll be looking at is what we call the triple negative breast cancer, so TNBC. So just very quickly and shortly, I'm not in a position to the senior people, as we've seen. What maybe you might tell us, what do we mean? We know breast cancer, yes, but what do we mean by having it metastatic? What do we mean by having it as HER2 positive on something? Or what do we mean by having it as triple negative breast cancer? So that we just have that start from there.
So maybe I can start with the metastatic. What that means is the tumor has moved. Okay, in a layman, I'll just use moved.
Yes.
So we have the primary focal point of where the tumor is situated. In this case, we have the breast. Now, Due to either one factor or another, you'll find the tumor will sort of like segment, and a part of it or some of the cells will move. They'll go either to the bones or to the liver or to the lungs. So if one or more organs have been affected, then that's what we call metastasis. That is just simply that we have more than one organ being affected. Triple negative. So we have two kinds of tumors when it comes to breast cancer. We have tumors that are or originate from hormonal effect, and we have tumors that they have no linkages to the hormones. And this, we talk about the estrogen, progesterone. So triple negative, it means that that patient has no hormonal involvement. HER2 is also a hormone, okay? So that patient, the tumor is completely secluded from hormonal supply. So if it was positive for hormone use, then we'll give drugs that will suppress the effects of hormones on that particular tumor or in any other part of the body. And that's where we give now the Herceptin to mitigate on that. I think.
Yes, we're able to understand. Finally, get to understand what we mean by TNBC, what we mean by HER2, what we mean by metastatic. It's not just breast cancer. We also have the different classes of that. So this is, we say that metastatic triple negative breast cancer is the most aggressive according to what is published out there. And having the lapses between the time will lead to the cancer continuing to become more aggressive. So this challenge was to check factors that might influence that time lapse, right? So between your screening, the moment you're screened, you're told you have XYZ, and the diagnosis aspect, which later on leads to the treatment that is scheduled out for you. As you've seen, there are different types of breast cancer. We don't all treat with the same drug, for example. So I used the basic, the normal gradient boosts that everyone uses in Datathon. So it's either XG boost, light GBM, or cat boost. So they're gradient boost techniques, machine learning algorithms. If we start machine learning algorithms, if we start going deep into detail, we will never finish. But yeah, basically the notebook will also be in our GitHub, but they're machine learning algorithms. So they use the gradient boost technique using the boost. We have the bugging and the boosting. Make sure you check what that is. So these ones use the boosting aspect, and they're super popular. So just the importation aspect, I usually have a list of the importation. Then this is how our data set looks like. Just to remind you, that is the test data. So we had the test data separated for us, and also the train data, which kind of looks like this. Then we've run this before. So this is basically the information of how our data set looks like. So we can straight off the bat see that in total, we have 12,906 entries. So the non-null count that tells you if it's null or not, and then the data type of this given column. Then the next aspect is getting a feel of how your data looks like statistically. So on a rough basis, this is how you'd basically plot out your numerical values, right? So to create that mean, standard deviation, maximum, and the mean value, right? The smallest value. So these features get to help you understand the distribution of your data. How much is it deviating from the mean? And as a statistician, which I know you all are, you all know what that would mean. Look at each point. We have 83 columns, get to analyze and see if the type of distribution that each column has. So that's a basis of what you would have also done. Then for the categorical columns, you also get to do what we call the counts and the unique values. So you get to do the count of the available items and then the unique categories that we have. the top occurrence, so in terms of the mode frequency aspect, and what frequency does it have, just to have that analysis of seeing how this pans out within your data set. So this is also just part of understanding your data set, which is usually the first steps. Then the next aspect is looking at if you have any null values. So looking at it in terms of the type of model that you might want to use. Some are not very welcoming when you have null values, right? So you need to kind of deal with that. So that's one of the aspects that we get to do in that area. Then this is just a total of all the columns and their names, how you'd basically get to look into them. Then just a sample basic exploratory data analysis. This is something that would have taken forever. So there's this column that is in text format. So we need to deal with this and see if we can extract more information out of this column. So this was basically the diagnosis description column where the doctors, I'm guessing, or whoever was writing, wrote some description of what they saw within the patient. So basically, this is how you kind of get to deal with that, removing your stop words. Stop words are basically words that do not have any much information in your data set. Get the length of the words, get the how many times do these words occur to kind of display this. So all this was marking up to this word count, or me creating this item right here. Where are you? Where's my cloud word? This cloud word right here, or maybe just the frequency table that you might see when you get this notebook. So this frequency table just gets to show us that feel of what was being diagnosed, or that description, and we can see that female and the breast, right? Because we also do know, or based on our data set, we did get to see that also men, a very small percentage of men, right? Right here, for example, there was a count of men occurring, the name male occurring. So it might also occur in males, but very, very small comparing to this aspect. So maybe a doctor, maybe in most cases they'll write, maybe this person has malignant, has a malignant XYZ, the person is female and it's breast cancer. So we are guessing this were some of the most used words while describing the diagnosis. So that was generally that column. Right, then this is also just another sample of how you'd basically get to plot the, what do we call it, the distributions, just to kind of understand. You might have your mean, your max, etc., but we still need to also understand generally the distribution of your numerical columns, just to see how they sway in terms of distribution. What type of distribution are we working with? This is just another one. This was for the patient age. With the fact that this will get to bin this up, I explained why we need to bin this up in our last session. So I have an interesting question. What type of distribution is this? Normal? Normal. Why normal? Thank you. It is a bimodal distribution. So because we have two modes. This is usually an issue in most cases that you might have to deal with within your data set, because this means you have two distributions with two different properties within your data set. So if I ask you, for example, let's try and see where the mean would be. Will it be in the first distribution or the second one? But in this case, the patient's age will be binned, so this is not much of an issue, but this might be something you want to look into if you have within your data set, just because of the statistical issues. And if you can see, the first distribution is actually, what skewness is this, left or right of the first one? You look at your toes. So that's the left. Always look at your toes. So the way your toes are curved, so that's the left. So this is the left, it's swaying towards that. So that means which one is greater than the other, the mean or the standard or the modes, which one is greater than the other. They usually differ with your right and left. If it's a normal distribution, you know everything is at So look into that and see if that is something you might want to kind of deal with. Right, then this is basically looking at the region, because we remember we had regional aspects within our data sets, kind of picking up that different regions might have different access of care, despite also being the US. We know the racial Hispanics have different access. We've had these things on CNN, I'm quoting CNN. So then there's that aspect of also similarly what we've done to the rest of that, the age, just seeing that age distribution between the different regions. So this is something you might also want to explore, just to get that exploratory analysis, just to get that understanding of how your data set looks like. Then this is basically the same thing. This was our output column. And you get to see that we had days diagnosed after 90 days being higher than diagnosis days. So most people actually get late diagnosis, right? So, and we're trying to see what features this might actually influence. Then another issue would also be, or some of the categorical columns that we can use. We use pie charts for that. We look at the distribution in terms of race. We see whites being more on here, the Hispanics, the others, the Asians, and then the 16 was African Americans or the Blacks. And then we also have distribution in terms of the pair. So each pair has a different cover. So a pair is what reimburses you, right? That's what we said last time. Right, then we can move on to the next aspect of the feature engineering item. So the first one was basically, and I picked some from some of the solutions. I tried to find a Kenyan solution, but didn't get one. So there's the aspect of mapping the ICD code mapper. So we had two ICD codes. So the ICD code is the International Classification Disease. We have 9 and 10 in this data set. So the International Classification Disease, as we mentioned last time, that's what is used. That's the code that is used to kind of it's the speaking language of doctors, if I might call it like that. Makes sense, right? If I might say it like that. And then the other function or the classifier. So all this was the data imputer, the missing data imputer. So all this, you basically put them up all together and use the make pipeline. So the make pipeline that sits within sklan, this was just a basic result where you run the pipeline to clean out your data. The pre-processing aspect happens. Then the other one was the age binning. So we said it's always better to bin your ages, to have that grouped up information, other than if you only have 18-year-olds, how much information will I get out of that? As per 18 to 25, we have that range. And this way we're able to tell that this range of this range of people has is more potential to a certain disease. Then we basically get to build our pipeline. You know the basics of doing this. So this is just the code of looking into that. And as we mentioned, these are the classes that I did have. Then these are basically the columns when you're training. So this is our training data. We remove or drop the predictive column, right? So that's just one of the aspects that we all know, or how we kind of get to do. And then we do the fitting and transformation using the pipeline that we created. So this was the name of our pipeline. Then we fit and transform to transform our data set. Then after that, we get into the modeling aspect, assuming now that, not assuming, with the knowledge that now our missing columns have been dropped, and so on. Our age has been binned. Then now we call our model, which is our cat boost classifier. That's I've already explained, that is one of the ML algorithms that uses the gradient boost technique. So we get to put this up the usual way, set up your parameters, the parameters that you think you might need and which you might tune later. I didn't get to the tuning aspect. you put that up, and this was from the first fold up to the 10th fold. So each fold, after all the folds had run, this is was the AUC, so the area under the curve score. So the closer it is to 1, that means your model kind of performed better. Then your matrix, your confusion matrix, just to see how it performed between the 0 and the 1 class, right? So did you get diagnosed before or after 90 days? So looking at this, these are usually our 2 points of concern. So the FP and the FN. So it is for you as a person to know which one to decrease depending on the problem that you have at hand, right? And then finally, this is the computed feature importance of the model. And according to this, the encoded ICD-10 indicator, because basically that was what would tell what type of breast cancer you have. And moving on to just what Tanya just mentioned, look into why these were actually selected up by this model as the best features, or not the best features, are the highest predictive aspects in terms of predictions. This were looked into that. So that follows up to the breast cancer diagnosis code, the patient's age that we created after binning up, and then the diagnosis description that we had on there onto the first, because I picked the top 50. Yeah, the top 50 to kind of be presented out. So that was kind of a rough idea of how you would have handled it out or looked into the problem or the thoughts that you would have had while trying to address the problem in that aspect. So that's just a rough of it, and maybe we can chat a bit later about it. So
Thank you very much, Diana. Thank you, Diana. We really appreciate you walking us through the notebook again. And I know you've seen this data for like a million times since January. So thank you very much. But with a show of hands, how many of us participated in our datathon this year? Datathon. Because Diana has rushed like ile ambulance ya kwenda Aga Khan. Yeah, thinking that we were all there, but no problem. We usually host WiDS Datathon every year. So please just check it out. What? Yeah, twice. This year, you're not sure, but we will try and host it twice. There is yeah, Jennifer is reminding me that we should actually host it twice this year. So we had a wonderful challenge, which she has talked about. We will share the notebook with you after, so that you can just go through it. But I hope you got something. Thank you again, Dana. Can you please clap for her again? I think from this point, let's just take like 5 minutes break, like, yeah, and come back 4:45. 4:45, we will have 10 minutes, 10 minutes, 20 minutes, 10 minutes each presentation for spotlight sessions, and then we will move to panel discussion session. Honestly, I think we are going to sleep here, but anyway, we are going to try our best and rush. So maybe we just like stretch. Jennifer, do you mind like stretching us a bit, and perhaps we grab water as we are doing that, because honestly, we need to stand up a bit. Jennifer, something for 5 minutes, and then we just come back for the next session. Spotlights.
Hi, everyone. Thank you for coming. Again, I'm Jennifer. Also, I don't know how to stretch you guys out. I don't know how to stretch you guys out, but okay, I just have some, because we have been talking about AI, and I just have some questions, like just some thought-provoking questions for you guys. I just want to know your opinion. So would you guys, so far with all that research being done by IBM and everyone here and all those data scientists, would you guys trust an AI diagnosis over a doctor's diagnosis at this point? Yeah, would you guys trust an AI diagnosis? Like, who would trust an AI diagnosis over a doctor's diagnosis? Why not? And you wouldn't. I trust them at home. I usually ask ChatGPT every time whenever I'm sick. Anyway, and then the other, okay, if you don't trust it right now, do you think that in 10 years it will be in a position where you can trust it? And AI, or maybe even it can replace the primary doctor. It can't.
No, I don't think so. They'll have to work it hand in hand.
Really?
Yeah.
Okay, maybe then would you trust it for at least for the diagnosis part?
Complementary.
There should be a human in the loop.
There should be one.
Human in the loop. We don't want to replace humans. We want human.
Okay, we'll see about that.
Be human in the loop.
I take out plastic.
You're building a climate terminators here.
What is called with the gap, the cognitive ability to even human beings to a significant extent. It's close to impossible to eliminate human element.
Okay.
That's my opinion.
Okay, I'm not trying to replace humans or anything. I just wanted your opinions. And also, would you guys be like, let's say if you were to like, can you give your health data in exchange for like a 10% discount in healthcare?
Yeah.
You would it?
I don't know. I feel like as long as it's anonymized, because sometimes you might give out your data and then it leads to a lot of discrimination and bias. I don't think we've gotten to a point where you might not be discriminated if you're to give out your health data.
Yeah, that makes sense.
Yeah.
That makes sense. But yeah, if anonymity is there, so you definitely share your data.
Exactly. But at the same time, can you trust them to anonymize? How?
We have that data protection policy all over.
Yeah, but before I get there, it's a bit of a hot topic right now.
Yeah.
Yeah.
Anyway, guys, it's just have fun and socialize. And yeah, it's nice, and you can take that discussion to the other level. I'm not trying to replace human beings, but yeah, it's definitely making everybody's work easier so far. Yeah.
Thank you.
Thank you.
We are never going to be replaced. Practitioners advocate for implementing rather than replacing the agent. Thank you, Jennifer. I just want to like with you, yes.
Oh my God.
Oh, yeah.
Hey guys, now hello. Let's just come back, guys. Let's come back to ours. Let's come back and just go on because we time is going to be our big issue here. Okay. Okay. Jane, go back to your seat. And yes, thank you. Thank you. So our next speaker, and this session is for Spotlight Talk. Okay, 1 more minute for the people behind to just be with us. Okay, so this is going to be exciting session. So we've seen different talks, right? And now I mean plus practical experience of it. But then this is also going to dive deeper into specific projects that these wonderful women are working on currently, right, in healthcare, right? And so we'll have, I'm just waiting for people to come in. Okay, let's come in, guys. Okay. Yeah, so we are going to showcase some of the exciting projects going on in healthcare. I mean, as far as AI and healthcare and equity in general is concerned. So we are having Mutanu, and we'll have Dr. Nelly give us these talks. So we'll start with Mutanu. Mutanu is a research scientist with a special focus on machine learning and health policy. Concurrently, she's pursuing her Master's of Science in Bioinformatics at the University of She leverages her expertise to drive data-driven solutions. So please share your screen and let's just go for it. Is it here? And the people joining us online, I hope you can hear us. You can see, can you actually do something like present in Teams? It will allow you to. So, just present. Oh, we can see your screen. Just do your presentation.
Sorry, we're just putting the notebook up, but I guess I can give some background in the meantime. Like you heard, my name is Mutanu. I have a background in science and research. At the moment, I'm working in data science and I'm studying bioinformatics. So that kind of merges my interests. Today, I'm going to give a presentation on computational biology or bioinformatics, depending on who you speak to. They're the same thing, something a bit different. But for me, I kind of see them as kind of one and the same. So in terms of technology, does anyone know about Moore's law? Wait. Who said yes very loudly here? So it says basically, as the technology that you have to do something improves, the cost of doing it decreases essentially. So the as computational power is improving, your cost of doing stuff like modeling and everything is decreasing. So here we see Moore's law, which follows this kind of trend, but with DNA sequencing, um, new technology has essentially reduced the cost really exponentially over time. So in terms of the new technology that we have available for, oh, sorry, in case you're not familiar with DNA, essentially it's the code that runs your body. So it tells your body what to make, when to make it, how much of it to make, what to do with it, those kind of things. So we try to look into DNA to just figure out how does the body work. And in that, we can actually figure out how disease happens, how we can treat those diseases, and basically just what's behind whatever is happening in our bodies. So in terms of DNA, there's projects that have come up that really aimed to sequence the entire human genome so that we can understand human health a lot better. And those projects really drove the progress of bioinformatics and computational biology over time. So the cost of sequencing has really been decreasing exponentially. And what does that mean? And in conjunction with all these other projects, it means we have a lot of data, huge volumes of data. We now have technology where we can do one experiment, and on one sample, you can get like tens of thousands of data points. So we have a lot of short and wide data rather than what we're familiar with, which is long and narrow, I guess, data sets. So this led to an issue where we were wondering, how do you analyze this data? How do you make sense of this data and how do you use it? So essentially, we've had to move towards data science, data analytics technologies, and using those to understand our data better. So some of the tools that are used in computational biology, so we have databases. So all these projects, they mostly funded because funding for this kind of research it's very expensive research. So it's usually funded, but one of the caveats of this funding is usually you need to make your data accessible. So we have lots of databases on DNA, protein structure. So proteins are made from DNA instructions. So protein structures, we also have data visualization as a tool, things like clustering, just understanding data in general, machine learning algorithms. So we can predict protein structures, we can predict protein interactions, and then we can also use them for clinical data and look at what's the correlations between these two. In terms of literature review as well, we have AI-based tools. How many of you have used PubMed before? Yeah, so that's a tool that we can use for literature review. And also wearable devices. So like with the rise of using IoT in healthcare, that's giving us a lot more data that we can use, and both in the clinic and in research. So one of these tools is AlphaFold. There's a video, I think, that's meant to come up, a very short one. Okay, so the video seems to have disappeared, but it was, yeah, okay.
Should I say it? Oh, it's going to YouTube. It's going to YouTube. So just leave it.
Yeah, so basically she was just explaining what this database is about, but essentially it's a protein structure database. So it's essentially a simulation of, if you put these two proteins together, how would they interact, where are they interacting, and what happens when they interact in this way. So developed by DeepMind in partnership with MBL's European Bioinformatics Institute. And the database has actually contributed to over 1,000 published research papers. Over 200 million protein structures have been gotten from this. Over 1 million users have used it. So this is really fast, and it's much cheaper than going to the lab and doing the experiments. So if you think about a situation like drug discovery, so you can find out this disease is caused by some kind of problem in this protein. So if we're looking for a drug that can help this disease, pharmaceutical companies usually have banks of drugs that are available but not in use for one reason or the other. So we can look at one of these proteins and one of these processes and see which proteins can we use in this process or in a drug that can help with this process. So maybe something is wrong with the folding process. Maybe we need a different type of helper to help that folding process along, those kind of things. So these are the applications. So we have precision medicine. I think that's been mentioned a couple of times. So the approach that we've been using is, you have this disease, we give you this treatment, all of you. If it works, great. If it doesn't, I'm sorry. But now we have a more personalized approach where the treatment essentially depends on the type of disease you have. So we test whether it's DNA, whether it's blood, whether it's urine, tissue. We look at which group are you falling in based on your characteristics, and then we treat you according to whatever that is. So we usually find that the effect of that treatment will be, the effect size will be higher, and also you'll probably get less side effects from using whatever treatment there is. So that's the clinical application. We can look at policy also, ecotoxicology and surveillance. So in terms of surveillance, we can think of things like cervical cancer, the pap smears. We can think of things like testing for certain variants of genes that cause certain diseases, things like sickle cell, things like cancers. Ecotoxicology, we're looking at how does our environment affect our health, essentially. So we can pick even samples from, let's say, a river or wherever, look at the chemicals in that and how are they affecting what's happening in our bodies. Research as well is another big one, just very widely used in research in terms of synthesizing the data that we get from, whether it's the clinic, whether it's the lab, wherever it is. And in pharmacology, so I'd mentioned drug discovery, development, and repurposing. So those in the drug banks and clinical trials as well, you can see. So in personalized medicine, just a bit more about that. So it can be used both in diagnosis, prognosis, and treatment. So diagnosis is basically what is going on with you. Prognosis is how is this likely to affect you? And then treatment is what can we do about this? So we look at molecular markers of disease. So we can look at surveillance, we can make our diagnosis more specific, and we can also look at treatment plans that are personalized. We can also do patient stratification. So look at this patient is in this group, so we'll treat them this way. Looking at drug efficacy, so the utility of that drug or how much of an effect it will have, and also the side effects. We can have group-specific treatment strategies. Immunotherapies is something that's really coming up now, and that's really involving computational biology. I think that's something that's quite popular in cancer right now, cancer treatments. And then risk and outcome prediction. So we can try and see what's the risk of you having this certain condition or this certain mutation, whatever it is, and how can we predict, are you going to, like when a doctor tells you have this long to live, maybe that can be somewhere where we use computational biology. So I just wanted to take you quickly, like super quickly, through okay, a notebook. So this is one of the assignments that I took for my course. And essentially we got an data set that's publicly available. And we wanted to, well, they had already used the data for whatever their purpose was, but our assignment was to look at the different outcomes that are in the data and see, can you actually use machine learning to predict those kind of outcomes? So we have gene expression profiles. It's just like, how much is this gene being expressed? So maybe like if I can think in code terms, how many times is this code being run, or how many times are we producing this thing in this condition? And then I don't think you need to know any of the rest, to be quite honest. So we can scroll. So also another thing was to look at whether one method is just as good as the other. So in low resource settings, so this is like a setting like ours, some of these technologies are not widely available or very cost effective. So we're looking at, in these settings, can we actually use this data to accurately look at these kind of outcomes, treatment outcomes for the patients? So here's the data. So we have clinical metadata. So that's gender, age, and the subgroup. So those patients are already grouped. Then we are supposed to predict these endpoints. So this is one indicator of poor prognosis or high risk cancers. Then we have the stage of cancer progression, high or low risk patient, progression of the disease, and the probability of death from that disease. So those are the endpoints we were trying to predict. So we have some missing data, which probably came about in the course of that clinical trial. And then now here is the data that we're looking at. That's the expression of these genes. So looking at the data itself in the clinical okay, this is a general EDA. I may not go into it too much, but we see that there's differences in the group. So this is just looking at gender versus the status, looking at gender versus stage of disease versus high risk, all these things. So just taking a look at all these factors and how they influence our outcomes of interest. So we find like something interesting here is when we look at progression versus death. So death only occurs when the disease is progressing in this case. So those kind of things are the ones that we are looking into. So that's the EDA. I won't go into that too much, it's quite extensive. So the first thing was to look at, because we had missing data, look at our common samples. So we joined the data together, got those samples, and then looked at the shared samples. Those are just Venn diagrams of the data, merged the data, and then so here we're just pre-processing the data, making sure that everything is okay, everything is encoded well and all that. So now we split our train test groups. So we have our train and test for the gene expression data, then our train and test for each of these endpoints that we're trying to predict. Then we pre-process the data and then look at an unsupervised analysis. So with PCA and k-means. Oops, this notebook is somewhere here. So with PCA and k-means, we're looking at some good clustering between the different groups. So that kind of algorithm can also be used to stratify the patients in whatever group we have in the trials. Sorry, I'm trying to really rush through this. So in my model, sorry. So we are selecting our features, defining our target and our features, and then we have some imputed features as well. We've dealt with data imbalance because that's something you might deal with a lot in healthcare. More than likely, your patient will not have it than having it in any kind of research study. And then so this is upsampling the minority class essentially. So here we are looking at a feature selection algorithm. We have a lot of features in this data set, especially the X1. And these are just different gene identifiers. So we do some hyperparameter tuning, and then this is now a random forest model. So we are looking at the clinical genetic subgroup. I think I'll just only present this one. So that's a group of whether you're in maybe a low risk, high risk, the type of subgroup that you're in, and that would probably determine what kind of prognosis, what kind of treatment that you would be, treatment group you would be placed in. So using a random forest model, you have your feature select, your hyperparameter tuning. So these are the parameters that worked for this data set. We get quite a good accuracy. The F1 score is high, which is good considering that the data set was a bit imbalanced. And the AUC is also pretty good. The confusion matrix looks relatively pretty good. And this is what the ROC curve has. So now we're looking at our feature importances. And these are the top features when it comes to that. So we would look at which genes would mostly determine what is actually happening in the body. So from these genes now, you can go to those databases that we're speaking of, and we look at what is this and what is it doing in this case? Is there any, we can even do a literature review and see, is there any indicators that this could be important in doing this diagnosis? So here, just plotting one of the features, I think this is the top one. So we see there's a big difference between clinical genetic subgroup 0 and the rest of them. So that's probably going to be something that's important, and you need to look into that when either diagnosing or stratifying your patients for treatment. This is another one. So we see that 0 is, sorry, I can't really remember these groups, but I believe 0 is the one that is not a progressed stage, and then the rest are various stages of progression. So yeah, we can just plot our important features versus what their distribution is across that feature. And then that can give us more of an indication of kind of more explainability to that model and that process. This is one application. I didn't really want to go into the gene data and everything too much because data sets look very different from what you're used to, and maybe may not be as applicable, but this is something that is quite applicable even in the clinic and in diagnostics, in prognosis, and in treatment. Yeah, I think that's the end of my presentation. No question?
Yeah. Thank you very much, Mutanu, for sharing with us your work. We have just one question, right?
Yeah,
just one question.
Thank you, Mutanu, for that. That's quite super interesting because I know your position is very special, having the domain expertise and the technical expertise in one. So in the demo, and thank you for showing us some of the work that you do. So in that case, because what a small thing I understood from the data set, what was your initial K maybe for the K means? Because I'm trying to see how many groups maybe did you initially put? I'm trying to see because if you use K means, you kind of have to have the initial grouping knowledge. So how many will that be? Or how would you choose your initial K, given that you maybe have different subgroups? Which group would you select the null for?
Sorry? Is it random?
Yeah, I think it's more of like a search for the best parameter in the sense that what gives us the best groupings.
All right.
Yeah. Yeah.
Thank you very much, Mutanu, for sharing with us your work. Once again, let's thank you. Many thanks, Mutanu. Thank you very, very much again. Our next presenter is Dr. Nelly. Dr. Nelly is a digital health business analyst and researcher with a background in pharmacy and medical physiology. She holds certificates in data science, stroke AI, and HL7 hyphen F. Oh my gosh. Okay. And just like that, my presentation disappeared. One moment. Let me just bring this back.
No problem.
Yes.
All right. Thank you very much. So, my name is Nelly. I don't think we need to go into that deep introduction. You can just go straight to the slides. No, I will introduce myself very simply. So, I'm a pharmacist by background and medical physiologist, and currently work in the digital health space. And it is such an honor to be here today. I mean, I've just been thinking to myself how refreshing it is to sit in a group of women who are standing here talking very technical stuff, who know their stuff. I mean, it's almost giving me jitters because it's so good to see women shining, women who know their stuff, and not just juju too. Like, we really know our stuff, and it's amazing. So
I have
no.
introducing you. So she has a profound belief in the transformative power of digital technology within healthcare. She serves as the health data science research and innovation lead at Intellisoft Consultant Limited. Pioneering health IT company based in Kenya and working across sub-Saharan Africa. Hiyo yote ulikuwa unataka niwache. I can't because this is so inspiring. Thank you very much. In a moment, I will share your slides.
Right. So I'll give a presentation just really talking about how far we've come and just drawing upon a lot of the things that have already been said honestly, and just trying to think about how can we apply how can we improve equity in healthcare using AI, using data, using technology. So I'll be very brief. So as I was preparing for this presentation, I reflected and I was like asking myself, how far have we come? And I thought back to the very first International Women's Day, the official International Women's Day, and it was held in 1911. So 1911, my great-grandmother was not even born, and there were women somewhere in the corner of the world fighting for equal pay, fighting for equal economic opportunities, fighting so that domestic violence against women can stop, fighting for more affordable childcare. 1911. And just thinking about those women in 1911 and every other year, and all the women that have come after that, fighting for education, fighting for women to be able to vote, and sitting here in this room today and, seeing how far we've come and seeing, all these women educated, all these women able to vote, all these women masters in their art. Honestly, I think we've come a long way and we all deserve a round of applause. The people who've come before us and all our predecessors, they all deserve a round of applause, and so do we. So go ahead. Mhm. Right. Yeah. So I wanted to also, as I was thinking about now, just homing into the theme of this year, equity in healthcare and, with a focus on cancer, I also had a story about this woman. So if you've worked in cancer, you've probably come across the story of Henrietta Lacks. So Henrietta Lacks was a woman who lived in the United States in the early 90s. So she was a Black woman, and after at around 30 years, she had her last baby, her sixth child. And then she noticed that she had lumps in her cervix. So at that time, the only hospital that would take Black women was the John Hopkins Hospital. So she goes into John Hopkins and they take, the standard procedures. They took a biopsy, which they didn't tell Henrietta about. So she got some treatment, but that time, cancer treatment was not advanced, so she died soon after. But the biopsy they took, of course, was stored. And after some time, they discovered one thing about Henrietta's cells. They were not dying. Henrietta cells were immortal, and they have since then been used to advance a lot of research in health, a lot of science, and actually 3 Nobel Prizes have been won because of science and work and research that has been done on the cells of Henrietta Lacks. They're actually called the HeLa cells. So the reason I'm giving this story is because statistically, a Black woman diagnosed with breast cancer stands a 40% chance of dying, her chance of dying is 40% higher than her white counterpart. Yet, all the research that has been done in cancer, a lot of it has been powered by cells that came from a Black woman. I mean, when we're talking about disparity and inequality, it's right here, right? And you ask yourself why, all these years of research, has there not been data that we've mined from this work that, we can actually leverage to help us bridge these gaps? Or are we just, are we blind? Or is it that these minority groups are not represented in the people doing this analysis, in the people actually, mining this data and going through this data to help us, to actually advance our agenda? And so I'm very, very inspired to see the women who've come here and, presented work that they are doing in, in data science, in analytics, in, just to explore how we can apply AI and data science in healthcare, because that's how we are going to bridge such gaps, that we actually use data from a minority group, yet the minority group still suffers. I mean, Henrietta's grandkids and her daughters still stand at that, they still are more likely to die from cancer, yet she has led breakthroughs in cancer. So, let's go on just doing the amazing work that we are doing. Right. So then I also was thinking about a story of Wanja. I've anonymized it or just changed it up. She's my neighbor and she was diagnosed with breast cancer. And so it was stage 2 and she was given the standard first line drugs, but she wasn't responding at all. And I think Mutanu, you've alluded to it, right? So she was not responding to it. So she had to have a double mastectomy, started her on radiotherapy as well, but still her cancer advanced, and this just speaks to what Mutanu was talking about the one size fits all. I mean, she was given the standard drug that any other cancer patient, with breast cancer would be given, but she's not responding. Why? Because clinical trials are done in a population with different socio-demographics, with different genetics, with different lifestyle. Yet to expect that this same drug is going to come to work in a person who's grown up in a different continent with different genetics. So she didn't respond, she died. And that is why we are now, it's a use case for precision medicine. So, I mean, when she didn't respond, if we had the resources, we should have taken Wanja, done her genetic tests, studied her data for the last 10 years, and then discovered, okay, based on her characteristics, based on her genetics and her data, then, this other targeted therapy would probably work better for Wanja and not the standard regimen. So there are different use cases that we can actually, look at and, and use them to inspire us in our journeys, in data science. Yeah, so I think this, speaks about, so Wanja's story is really precision medicine, and it's a use case or demonstrates precision medicine. So yeah, go to next. So next is digital health. See, this is where I currently work. So there is currently a wave of digitization, so every government, the African Union, WHO, USAID, everybody is pouring serious money into digitization. Today, if you go to Aga Khan, there is no file. Everything, there's no paper file. Everything is on your computer. I actually have a personal health record on my phone, showing all the tests I've had at Aga Khan for the last couple of years and all my data. So in the next 5 years, in the next 10 years, that's going to be the status quo that you can go to. You can actually have millions, you can have 10 years worth of records of patient data. But I mean, what good is that data sitting in our hospitals if we actually can't use it? But the skills, the passion to actually get insights from that data is in this room, right? You have the skills, you have the interest that can help you go to Nairobi Hospital and tell them, you guys have 20 years worth of data in a digitalized system. You go in there, you do your magic, and you're able to tell them that, from this data, I can see that kids who are born of mothers who have diabetes, after 20 years, they present showing this kind of condition. So we need to prepare for this. Or you can say that Nelly, based on her data, she is most likely to respond to this particular drug. So this is a use case, and digital health is just starting. So I think it's the high time, if you haven't, put your foot into it, or you're thinking about, okay, do I get into data science or do I not? I mean, it's a use case, and I'm telling you, we are doing massive projects all across Africa. I'll give you an example of a project we're doing in Botswana. We have developed a digital system for the public health system in Botswana to be used in 400 facilities. It's funded by the ministry. So you can imagine the amount of data Botswana is going to have in the next 1 year, not even 5. I mean, if we don't have the skills, the people to help governments make sense of that data, to inform policy, to inform, how they buy their medicines, how they buy their equipment, then the data science women in this room will have failed us. Yeah. So one of my last stories, in 2021, I worked in Turkana County as a pharmacist. And if you know about Turkana, it's one of the most marginalized regions in Kenya. So you go there and you actually think you're not in Kenya. Why? Because you don't, the disease you find, your leprosy. Leprosy was a disease in the Bible. It's supposed to be, it's supposed to be one of the diseases we got rid of. But there was leprosy in Turkana that we are dealing with. You go to Turkana, one of the diseases you deal with is called leishmaniasis or kalaza. It's a neglected tropical disease. That means, the whites don't think it's important for us to invest in this disease because, I mean, it's affecting guys in some weird country across Africa, just a community. Why should we invest in it? So those are your typical diseases. And of course, there was some malaria. What you don't find there is diabetes. You don't find hypertension because people are malnourished. There's no food, honestly. But you go to the pharmacy, the shelves were always empty. We don't have drugs for leprosy. We don't have drugs for leishmaniasis. We don't have drugs for malaria. But the shelves are always full. We have drugs for hypertension. We have drugs for diabetes. Why? When we have our leaders and policymakers at the national level plan, the same drugs are sent to every corner of the country, right? We don't ask ourselves, okay, in Turkana, these are the disease patterns, these are the disease burden. Therefore, let's take these drugs to that county in Nairobi. There's lots of hypertension, there's lots of diabetes. Everyone is eating junk food. Let's take all the diabetes drugs there. Why? Data-driven healthcare. Is our healthcare system data-driven? I mean, maybe they're making an honest mistake. They don't know. Yet the talent is right here. You go to Turkana County, crunch into their database, show them the data, because numbers don't lie. They will see the data and they will actually now change how they procure, how they order drugs from KEMSA instead of just, going through that essential drugs list and just ordering everything there and not, maybe ordering less of the diabetes drugs and ordering more of the drugs for malaria or leishmaniasis. So, I mean, the use cases are immense. And I mean, when I saw this in Turkana, I was like, I am not going into clinical practice. I want to be in, I want to be in data, I want to be in technology, because that is where, you sit there and just pop up some infographics, you pop up information that your policymaker can understand, and you can make a big impact. So this is another use case that I thought, would be nice to share here. And then finally, I know a lot of us, actually most people who get into data science, you've probably not gone into not done a master's in data science. It's probably something you self-taught. I self-taught myself. So I was doing my pharmacy and I was also learning data science. The only, official training I got was a fellowship from Microsoft on data science and AI. But, you literally go through all that, you go through, you download that notebook and you're just, trying to, figure out what are these XGB boost and all those, you literally teach yourself. And when you're doing it every day, it doesn't make sense. Sometimes you want to quit and just, I don't want to do this. Then the more you do it, the more it becomes easier, the more it becomes natural, the more it becomes, it becomes like second nature. So you just keep on doing it. And then with time, you sit here and these things make sense. They are rushing through, but you're like, yeah, I know that thing. I know what they're talking about. So it takes grit and time, and takes God, it takes grit, it takes time. Just keep at it. And there are so many problems out there in the world that are waiting for you, that are waiting for your passion, that are waiting for your skills. So go on, and it was a real honor. And I hope we go on, I hope the women of 1911, they are the dream, we are the dream they had back then. So it's been an honor, and thank you very much.
Thank you very much. Thank you for sharing with us. Quite insightful. Dr. Nelly, we truly appreciate your talk. Many thanks. Can we please clap for Dr. Nelly again? At this point, let's just quickly have Dr. Wambui, please, over here, and our panelists, so that we dive deep into panel discussion, and then we call it a session. Thank you very much. Yeah, so we'll have Dr. Nelly take the seat. We'll have Doris. We'll have Terry. Please come forward. Dr. Doris, please come forward. Lilian, please.
Yeah. Hello. Yes. Hello, everyone. Hello again. My name is Dr. Wambui, and I'm very honored to be. Yes. I'm very honored to be part of these brilliant minds. Diana had said something about everyone being a statistician here, and I think I'm the least. I'm the least of the statisticians here, coming from someone who has a very bad PTSD of high school mathematics, whereby you see these memes that go around with teachers who used to give people maths results with the paper turned upside down. Or we also had a teacher who was a sadist who used to arrange papers in the order of marks. Like, so when he's giving marks, the earlier you're called, the lower your score. For some reason, I always wonder why he had all this time to actually arrange papers in the order of the least, from the least performing to the highest performing. Anyway, I'm very happy to be moderating a session of a panel discussion session of a topic I'm very passionate about, which is health equity. I am a medical doctor with a passion in public health, and health equity is one of the main things that I'm very passionate about. So today, these brilliant women will take us through this topic, and I will do a bit of an introduction. At least there's some, the bulk of them, you know them. For Doris, so one thing they didn't mention about Doris is that she's a foodie, but she hates cooking. She does. Dr. Nelly here writes poetry, actually, and she's hoping to publish at some point. So look out for her poetry book, right? Terry, I'm going to introduce her because she was not part of the panel. So Terry Mochire is a software engineer with a strong background in Android. in back-end development. She's a final year medical student at Kenyatta University. So her unique blend of skills allows her to bridge the worlds of medicine and technology. She's dedicated to leveraging the latest advancements to address the challenges and complexities of the medical field. Her ultimate goal is to contribute to solutions that enhance the lives of those in need, making a meaningful impact at the intersection of healthcare and technology. Cherry cannot ride a bicycle. There is a lady I want to, yes, we're going to Lilian. Lilian was also not part of the panel. So, okay, was not part of the speakers. So I'll also introduce her. So Lilian is a seasoned data professional with over 7 years of expertise, primarily gained in financial institutions. She earned her bachelor's in informatics from Strathmore University, and she holds a master's in analytics from the Georgia Institute of Technology. Passionate about unlocking the transformative potential of data, Lilian is dedicated to steering organization towards a more data-driven approach. She's currently serving as a data scientist at the Central Bank of Kenya, and she's at the forefront of driving innovation through data. So outside of her professional commitments, Lilian finds joy in spending quality time with family, friends, exploring new destinations through travel, and engaging in various physical activities. So does anyone know here of bridge bungee? There's a bridge called Bridge Bungee. Like there is which is the highest bridge where people bungee jump from? Anyone who has an idea? It's in New Zealand, I think.
Yeah, let me.
Oh well, so she has fiercely bungee jumped from the world's highest bridge, and she described that experience as both terrifying and exhilarating. So I don't know how many people can take that risk of doing that. I personally can't. So for the people who are interested in bungee jumping, I think you can see her after the session to actually learn what that entails. I am going to introduce Miss Tanya as much as she was here because I feel that she was introduced. Based on everything that she's achieved, I think it's good for you people to hear, yeah? So Tanya is a skilled engineer with a strong background in the Internet of Things, that is data analysis, machine learning, and deep learning. She earned a master's degree in electrical and computer engineering with a specialization in applied machine learning from Carnegie Mellon University. Throughout her career, Tanya has led several projects, including the development of data collection platforms, data analysis for remote monitoring and predictive maintenance, and the implementation of machine learning architectures for energy, health, and finance systems. Currently, Tanya is an AI research engineer at IBM Research Africa in Nairobi, Kenya, focusing on developing trustworthy and robust machine learning systems. She will soon be pursuing her PhD in computer science at the University of Barcelona with the AI in medicine lab. Tanya is passionate about advancing the field of AI globally, but especially in the sub-Saharan Africa, and ensuring that these systems are safe, ethical, and affordable. Right? She's done quite a bit. And the theme for this year's International Women's Day is invest in women and accelerate progress, right? So right here, we can see an investment in women, and definitely we are hoping for an acceleration in progress, right? So we will jump right into the panel discussion. I think some of the topics that have already been dealt with, but we'll just go through them. And I will begin with Terry. So Terry, as a medical student passionate about healthcare technology, what specific AI applications do you think have the potential to revolutionize patient care and outcomes?
Hello, everyone. Good evening. It's honestly a pleasure and an honor to be in this panel. I think the minds here are just mind-blowing. Not think of another word on the spot. So I will really echo the constant topic that has been the topic in this session, which is precision medicine. I think the one-size-fits-all approach in medicine is slowly and clearly being faded out because it's being proven that it is not as effective as we had thought of it to be. Especially now when we're able to study more about African or Black genetics and what our socioeconomic status and what our environmental exposure means to the medicine that we receive. I think we are better placed to develop medicines or to contribute to drug discovery for our own population. So that's a field that genuinely is exciting to see, especially for our population, because we've always been the marginalized. Yeah. Apart from that, I think also predictive analysis of this, predictive analytics for disease is also a very interesting or encouraging field to look into, especially because we've always known prevention is better than cure. So if you can follow up patients and see who is more likely to get a certain disease, then you're able to tackle it beforehand. I'm actually currently working on a project that is involved in predictive analytics. So we are looking to see whether we can predict sickle cell crisis in sickle cell patients. As Dr. Doris was talking about, hapo kwa challenge ya data, we're deep in the thick of things with writing all those 1,000,001 letters and following up 1,000,001 offices. But essentially, our goal is to try and see whether we can predict a crisis in sickle cell patients and therefore have the patients seek healthcare before they get the crisis. So yeah, those are two fields or two subsets in AI in healthcare that are looking very promising.
Terry, I think that is very spot on, the precision medicine and the predictive analysis. I think this will go along with actually augmenting healthcare. So we'll go to Lilian. Lilian, from a data scientist perspective, what are the biggest challenges organizations face in harnessing the power of data and in this context to improve health outcomes? And how can we overcome these challenges?
I think I'll just echo what Terry has said and to say that it's such a privilege to be among women who are doing great things, not in Kenya, but worldwide. So I really feel privileged and I'm honored to be here. When we look at the challenges that organizations are facing when it comes to harnessing the power of data, I think when you look at the health context, we need the data first. That's the first thing. You need that data. And do we really have electronic health records in every hospital in Kenya or even in other countries? Probably not. So that's the first thing that you'll find. We don't have electronic health records. So that's the first thing that you'll need to tackle before you even now look at using that data. So that's the first thing. And even when you implement these electronic health records, then you have different systems in a hospital. I don't think you'll have one size fits all. So you'll probably have a system for X-ray. I don't know if I'm right here. You'll probably have a system for X-ray. You will have the pharmaceutical system. So there are different systems that you'll probably use in a hospital or in a clinic. You need to bring this data from disparate sources to speak to each other so that you can actually use it to create systems that can be used. So that's another thing. When you're creating or when you're implementing these electronic health records, that's something that you need to think about. The data that we'll have in different systems, they need to speak to each other. I think the second thing I'll talk about is you already have the data. Then the next thing is data quality. So is your data quality good? You're looking at accuracy, you're looking at completeness, you're looking at consistency. So those are the three things I'd mention in terms of data quality. So you've implemented your electronic health records, but is your data good enough such that when we now want to move a step forward and use this data, can it really help us? So is the quality good enough to help us actually make decisions? And I think the best thing probably that organizations need to look at when they're trying to have quality data is probably to implement a data strategy and governance such that you have a document and a guide that tells you this is how we collect our data, this is how we maintain it, this is how we analyze it. So everyone in the organization knows this is what we deal with this is how we deal with the data. And you will end up with very good data that even when you now come to build systems, create models, all those good things, you're working with good data because garbage in, garbage out. So if you have bad data, then there's nothing you're doing. And the last one I'll talk about is ethical considerations. When we're looking at health data, it's very sensitive. This is something that is probably very sensitive to someone. That's why even when you go to hospital, you'll walk in by yourself. You wouldn't just tell a doctor your problems in public. So I think you have to think about ethical considerations. So even when we are building these models, all these good systems, are we really thinking about protecting the patient? So are you informing them when you want to use their data? You can tell them, this is what we are trying to do. You can opt in or opt out. So I think those are the things that we need to figure out. And in terms of even creating policies, ethical policies and procedures, because sometimes you'll find that someone actually shares the data and they are not aware that they're doing a wrong thing. So when you educate stakeholders in the hospital, in clinics, and even in other places that are using these health records, then you'll probably have tackled the ethical considerations. Yes.
Thank you, Linda. I think I totally agree with you, and especially on the issue of educating the stakeholders. I think one of our speakers talked about the issue of they went to a public hospitals and you're trying to implement an issue to do with the EMR. And a nurse is someone who usually has very valuable information there. They can actually enter into the system. But if the nurse is not aware why they're entering, what is the use of this data, they don't do those things. Like they'll always want to go back to the big book they write. I don't know how many of you have gone to the public hospitals and they see a whole there's this big book, and people are so proud writing on this book. I always wonder, do people ever analyze this data honestly? I don't even think, I think it's so generic. Like they'll send at the end of the month, they'll send, oh, we saw 13 mothers within the maternity wing. These are the number of babies who are delivered. And you wonder, what are you supposed to do with that data? But you see, if we have like an EMR within the hospital and people actually take it up, because there's one thing having the EMR, and there's the other thing of people actually like utilizing it, then I feel like we're going to it's going to be a very good kind of investment. So then I'll go to Dr. Nelly. Dr. Nelly, as a pharmacist and a digital health expert, what role do you see AI playing in medication management, adherence, and patient safety?
Thanks. So I think the use of AI in medicine, we've talked about it, right? We've talked about precision medicine. We've talked about, I think I had a mention of drug discovery, computational drug discovery. And so I think that's one of the ones I'll home in on. So if you know how the cycle of how drugs are discovered, how maybe a company like Roche or Pfizer, so they'll probably, they start with maybe a theory of a certain groups of molecules that potentially could work. And then this will go, through a whole over 30 years actually, and a whole, a lot of investments like $1 billion actually go into the R&D to actually move a drug from potential to actually a drug that's viable to go to clinical trials, right? So sometimes they would even start with a group of like even 100 potential, candidates. And each of these molecules have to be taken through, you test them in a rat over and over again, then you come and you test them in cells over and over again. Then if you get lucky, you might get, go to clinical trials. Clinical trials have phases, phase 1, 2, 3, then you go to phase 1, then you're told, okay, it doesn't pass toxicity tests. So all the investment that you put into that go away. But now with AI, what's happening is that now we have computational drug discovery. And what you do is these 100 molecules, you actually you build models, and then you do molecular dynamics. It's a field. So you do molecular dynamics, and you actually from this 100, you end up with 10 possible. So you've shortened instead of investing in 100 and taking them through all this journey of potentially 30 years and $1 billion, now you have 10 reduced. which have a higher chance of actually becoming actual drugs. And so you focus on this. And as you're doing the in silico drug discovery, those 10 might actually reduce to the 5 highest possible drugs. And then so these 5 ones are the ones you now do, animal tests, you do you do the test in cells, then you do the tests in clinical trials. So that actually AI and machine learning has come to revolutionize drug discovery. So that's one. Then, of course, now in terms of treatment, it's now we are able to predict or to say that even design the personalized medicine. I won't talk about that because we've talked about it a lot. And then finally, maybe we talk about disease surveillance, right? So I think you remember during COVID, there was this infographic or this the data that was going around about how since the 1900s, we've actually seen a cycle of how pandemics come. So like every couple of decades, we have a pandemic or we have a global disease. And so through applying AI and data science, then we can actually, predict this even from on a lower scale, not even globally. We can even home down to, to countries, to regions, to even families. And then we are able to even plan for what drugs are we going to buy, what drugs do we need, what medical supplies do we need. So I think those two are areas where AI is potentially changing the field.
Thank you so much, Doc. I think that is very insightful, especially the issue of the AI helping fasten this issue about the drug discovery, because we find that the longer a company takes to discover the drug, the more expensive it is. So the patent they request for would even be 5-10 years. So you see that limits, especially in the in the low and middle income countries, where you find like right now, I know there are some ARVs that are in use in the West, but currently we can't use them here because there is a patent and there is no generic company that is allowed to manufacture that drug for let's say for a gap of 10 years right now. And you see, in the LMICs, we cannot afford a lot, especially on a large scale, the original brands of drugs because of the price, yeah? But you see, if a company is going to take, as Doc is saying here, as opposed to taking 10 years, then they're taking 2 years to manufacture this drug, then even the patent is going to be maybe a less time, and we can access these the great drugs and the new discoveries earlier, yeah? All right, so we'll go to Doris, our keynote speaker. So Doris, as a specialist nurse advocating for education and policy in tech-driven healthcare, what policies or regulations need to be put in place to ensure equitable access to AI-driven healthcare solutions?
Thank you, Dr. Wambui, for that question. And when we talk about policies, my colleagues up here have actually tapped on some of the policies that need to be in place. For example, we talked about confidentiality and data sharing. So we need policy that will govern that. We know we talked about, there was one of the participants who talked about the Data Protection Act. And there's a clause in that is talking about AI. But then we need to expound further on that. So it's more of building on the Data Protection Act that we are currently having to include some of the clauses that will make our patients feel at ease when sharing some of this data information with any of the institutions they'll be visiting. Also, we have policies on quality assurance. Quality assurance is how that data is gotten, how we are going to implement and use the data in developing algorithms that these AI machines will be, the output will be given. For example, if we are feeding a data on the risk factors of developing breast cancer, what are some of those information that we are keying in, so that we can get a cluster of maybe a patient who presents with A, B, C, D, we can put them as high risk or low risk. So we need all those quality assurance policies in place so that any tech institution that is coming up or maybe formulating AIs, so that we can be able to be speaking the same language. That will also bring about trying to mitigate the bias effect that AI can have. Also, we need policies that talk about the training. What kind of training do we need for the health care providers? I've had a lot of jargon here. And the only output I was in, okay, fine. So that means red is high risk. Blue is, that is the only information I know or what I can be able to gather from that. But when we go through the learning process of understanding, and the tech people telling us this is the information. So, Sisi, as we get this, and we know these are the risks. So it's for the tech people to tell us, this is what you need to tell us so that we can be able to create a software that will give the output that you're looking for. So we need the training aspect. Also, we need policies that talk about collaboration. How do we collaborate between the researchers, between the tech firms, between the healthcare providers? And to what degree of information do we share between the parties involved? So we need policies that also talk on that. Also on finance. And that is a very big area because Microsoft might say, we develop AI and then we sell it at how much? But then again, the question is, if the cost of using that particular software is so high, what will happen to the people in Turkana? What will happen to the people in Moyale? Or people in Tana River? What will happen to them? Because they cannot be able to access the software because of the cost implication. Because even currently, what we are trying to do in the cancer space is control the cost of cancer treatment. Because some institutions will charge exorbitant fees, others will be, mid-level. And as you can see, everybody is now running to the cancer space because that's where they're saying there is money. So we need policies that will stabilize that and make it accessible to people. We can look at, what else? The others I can, when they come back to my mind. Thank you.
All right, thank you, Doris. Those are actually very good. All right, so Tanya, how can AI-driven predictive analytics help healthcare providers identify and intervene with a risk patient population to prevent adverse health outcomes? How do you think AI-driven predictive analytics can help healthcare providers identify and intervene with at-risk patient population to prevent adverse health outcomes?
Thank you. That's actually a very good question, and ties in with into one of, I think I had a meeting with some clinicians for research that we are conducting, and when we were presenting some of the preliminary results in that meeting, it was basically we were telling them, oh, we're going to use AI to predict hypertension. But then the doctors or the clinicians there were like, why? Why do we need AI for that? Patient comes in and I just measure the blood pressure and that tells me whether they have hypertension or not. So to them, that did not really seem like a basic need. It's something cheap. Most hospitals always, when you go for triage, they always take your blood pressure. So that's something that's cheap to be done. But then what they mentioned that would be helpful for them is, for example, that co-occurring diseases. There are some diseases that are quite expensive to measure or to diagnose in terms of like the kind of the measurements they're needed. For example, like blood sugar, you only measure blood sugar when the onset of the symptoms start. But we want it to be preemptive in a way that before even the symptoms start, we can be able to tell when a patient comes in, that we've taken the usual measurements. Are they at risk for other diseases that could co-occur with what we've been able to measure. So that to me, sparked something as a technologist, as a data scientist. I wasn't thinking about what would be useful. Yes, it's cool to put AI on things, AI powered stuff. And yes, everything is there. It's cool, but is it useful for the person that I'm making this application for? So when we're talking about health experts, the doctors, the nurses, and even within the doctors and the nurses, they have different needs. A doctor wants, if we're looking still at the issue of predictive analytics, a doctor wants to personalize the treatment. A nurse just wants to report, at the end of the day, they just give a report on these are the many patients that I've looked at. These are the ones that we sent to this doctor. These are the ones. So the needs of the kind of predictiveness that they need, they're quite different based on what part of the treatment process they are in. So when we're looking at predictive analytics, especially for health professionals, of course, we want to be preemptive. We want to be able to say that person X has a risk of 40% risk of developing cancer, and it is because of this X, Y, and Z. What are the things that we can do right now? And then we want to be able to do it in a cost-effective way. So being able to know who to send for further screening so that you're utilizing the resources well in that health center or as a health professional. And then after that, now you can also put in, the personalized medicine, things like, okay, we've been able to screen this person, and everyone who's been screened, we've been able to give them a treatment plan that is optimized for their specific situation and their whole body. So it's just to think not what is the coolest thing to do. Yes, machine learning is cool, AI is cool, but try to find what is useful for the specific application. And when we're looking at predictive analytics, it's trying to have preventative care and not wait for the onset of a disease to be able to start treatment, basically. Thank you.
Thank you, Tanya. I think also thank you for bringing out the aspect of collaboration. I think it's very important so that we don't have people operating in a silo where we have the data scientist is doing their thing, the doctor is doing their thing, the health tech person is doing their thing, and everyone is working towards the same goal, right? But if we work together, then we are able to achieve more, because you will, like as you say, the doctor will give their perspective, and you will get your perspective, and you will bring someone like Dr. Lilian there, then see then how can we use digital, how can we leverage on this to actually, at the end of the day, everyone wants to improve the patient outcomes ultimately. Yeah. So the next question, this goes to all the panelists. So anyone can take it. So how can AI be leveraged to address disparities in healthcare access and delivery, particularly in the marginalized communities? So I think we've already talked about Turkana, the Tana Rivers, those the counties that are really marginalized. So how do you think we can use AI, and in this case, for access and delivery of healthcare to these populations?
Thank you so much for that. Actually, at the moment, we are in the process of adopting and utilizing AI. If you look at Kisumu County, they are piloting a process whereby they can be able to use AI in booking of patients, communicating to the patients about their appointments, being able to give them information about their diseases or any other diagnosis, and they can be able to communicate with their doctors while they're at home. We are also finding the field of oncology, whereby we are getting pap smear samples for cervical cancer for analysis, and we are sending them via cloud, whereby now a doctor who is far can be able, for example, a doctor based in Nairobi and the patient is based in maybe Migori or Tana River, they can be able to analyze the slides and come up with a diagnosis and send back the results to the prescribing doctor based in Migori or Tana River. So currently we are already taking in terms of diagnostics in basis of
ensuring that the patient who is at home can be able to access services. Now, we can only achieve that if we have infrastructure. So we need network. We're still having a bit of challenges in network so that whoever is there can be able to access data from Safaricom and be able to access the software, the platform whereby they can be able to communicate. So once that one is sorted out, we are good. So the main challenge at the moment is having a phone that can be able to access or connect the Android phones. Secondly, network is also a challenge. So that is what we are trying to see if we can be able to address.
Thank you. Dr. Nelly, you
Yeah, I just remembered something. Maybe some of us have seen the company called Zipline and what they're doing in terms of drug delivery. So maybe the warehouse is in Nairobi and they want drugs to go maybe to Turkana and the roads are bad, there's insecurity. So they just send drones with drugs to do delivery in Turkana. Of course, that drone is, of course, what's powering it. There's a lot of AI, right, in that. So I think that's also one that's actually happening currently in Kenya, in Rwanda. I think they're also in Zambia. So
actually, that is very innovative because what you realize, having worked in the public health sector in a remote area, I did my internship in Mwingi. Mwingi is in Kitui. I don't know how many people have been to Mwingi. Mwingi is quite marginalized. I don't like saying it's marginalized. They removed it from the list of marginalized areas, but when you go to the ground, actually that place is marginalized. So when we have such innovations where we are having the drug delivered through drones, then you can tell the patient actually, wait for your drugs rather than telling them to go home and come back. And these people don't even have fare. They don't, like, the bus passes. In many, there are places where the bus comes once in a day. When is the last time you heard of a place where the bus comes like 8 a.m.? So you miss the 8 a.m. one, it's until the next day. There are such places. Okay. So there's another issue that's coming up about how can we ensure that AI-driven healthcare solutions are accessible and user-friendly for diverse patient populations, especially those with limited digital literacy or those with disabilities? Because you see, the way we are talking about AI here, it's someone who's probably tech-savvy, who can use that, or someone who's has a smartphone. But what you realize, like, majority of the Kenyans don't have smartphones. They have like maybe the normal phone, the small phone. So then how can we make these healthcare solutions that are AI powered? Because remember, we want health equity. We don't want to benefit the people who have smartphones and the people who don't have smartphones or who are very marginalized, or people who have disabilities are not able to access the solution. So what do you think as some of the ways that we can help make these solutions more friendly to these people?
And start. So one of the ways I think about it is investing in user experience. You know, usually as engineers, or even from my experience, it's very easy for us to get technical. And when we try to explain to someone our work, we go very deep and jargons everywhere, and we don't end up doing anything. But at the end of the day, you need to first educate the user on what you're trying to sell or what you're trying to make them use. And one of the things that ChatGPT has been very good at is being able to improve user experience to a point where the user can understand and use it. Before ChatGPT, there had been all this cool stuff, deep learning models that have been developed before. Like in conferences, you'd go and some cool stuff were going on, but that wasn't being translated into a product. And the reason ChatGPT ended up having worldwide success is because, one, of its use of natural language. You literally just go talk to it in whatever language you have, ask it a question, it replies. You tell it, oh, explain to me what explainability is as like I'm a 5-year-old, and it changes the language and it talks to you like you're a 5-year-old. So that being able to customize user experience, and this is especially important for resource limited settings, whereby first we already have language issues. we can't just release English-based applications because not everyone speaks English. So you do need to be able to communicate with them on, even when you're telling them what the product is, you need to be able to help them engage with the product as in their own language. And then the other aspect of that we need to think of is, damn it, it was in my mind right now. Um, just give me 1 minute. It literally just came and okay, it will come back later. But basically, user experience, talking to it in like natural languages. So whether we need to convert, and also looking at aspects like education, awareness, not really education, but awareness. So people, they have phones, but not many use smartphones. And, how do we then introduce, because we also don't want to just make them stay. We also want them to be able to use some high-tech stuff, right? So being able to teach them in a way to adopt some of these technologies that are there that can be affordable at their hand, and then help them to understand and use the product. Yeah, I'll talk about the other later.
I think also, especially when you think about people living with disability, I think they need to come at the forefront when you're designing the product, not as a second thought, not after you've developed for, yeah, I understand that majority of the people may fall in the bracket of not disabled, but not developing a product with this group in mind and then having this ones as, oh yeah, by the way, let's also cover for this group. It's as you're building the product, for example, if it's an app and you're expecting it to be used, say, by people with challenges in hearing, then have you incorporated maybe text to voice already innately when you were building the application, or having that at the forefront while you were product designing. I think also just to build on what Dr. Ms. Tanya, was talking about. I'm sorry. I'm really trying to get the names right. So I think also creating awareness around the product so that we're not marketing these products as, this big, jumpy, scary, like you're making this person take a very big leap to getting to it. Bring it closer to the user, seeing that, okay, I can just go to this website and I have the product there. I don't have to go and line up somewhere and sign up for something, then that makes it more accessible and it's closer home.
All right. Thank you. Terry,
Can I just add something?
Sorry. Sorry.
I think another thing that we probably need to think of is cultural nuances. And especially when you look at sub-Saharan Africa. Maybe when you're looking at the Western world, maybe that's not a big deal. But when you're looking at sub-Saharan Africa, that's a very important thing that you need to think of. There are certain cultural nuances that you might not pick out, and you develop a product and people will not use it. And I'll give an example. It's not in health, but I went to a conference and it was something to do with climate change, I think. And one of the things they were trying to do is they were trying to help people in Western Kenya use more sustainable energy. And there was this NGO that went and gave people very energy efficient GCOs. They went to very many villages, they gave out GCOs, and they decided after 3 months, let's go and see who's using it. And they went to so many houses, they've just been put under the bed. And they're asking them, what's going on? Why aren't you using GCOs? And they're telling them, you see, in our culture, I cannot be using something that my mother-in-law does not have. So until she gets it, then I can't use it. And you see, you have gone there, you think you have improved the community, you have helped these ladies, but at the same time, did you ask them? Did you ask them, what are your cultural nuances? What do you believe in? What can you do and what can you not do? So I think that's also very important when you're developing product. Yeah.
Because we tend to adopt a lot of things from the West. Like those people don't think about those things. But when you come to the African context, and she's saying, you'll be shocked. Like even uptake of a certain procedure or even medication, you'll find that there are actually challenges. There are people who don't believe in like doing pap smears or going for breast examination or going to the hospital for screening, where we tell people, do your wellness checks. But there are people who believe that you don't really have to go to the hospital if you're not feeling unwell. Yeah. So thank you. I think in the interest of time, we'll bring the panel discussion to a close. I will ask for, yes, any question before I do the closing remark. Yes. Sorry. Hi. Can you hear me? Yes. Yeah. I also work in the disability space. I heard that you mentioned something to do with the disabled. Do you have like data concerning the deaf, especially on sign language, that is already pre-modeled? You went too fast with the whole translation part. So I don't know. Is there any data that is already curated, especially on sign language, considering it's really vast in so many countries, even in our own country, like you go to a place in Eldoret, the deaf in Eldoret cannot communicate clearly with the ones in Nairobi because if you sign something, might end up giving a wrong information. So is there any other place I can find the actual data where I can work in terms of translation?
I believe that question is get to me because I was done talking about this. Okay. I unfortunately might not have an answer to that. I'm seeing Diana doing a quick check here about something that she knows. So maybe you can consult her. Yeah.
No, did you say that you work with disabilities?
Yeah, mostly the kind of hearing.
Then you are the one who is supposed to give us the data.
The thing is, the data, I tried searching for one because I wanted to translate sign language for especially African countries, but I could not find one that is actually curated better. Mostly for the health, it's highly favored, but unlike the other part now, it's a bit difficult.
Interesting. I don't think we have, and it is a call for us to like.
I think most of them use ASL, the American Sign Language. The Kenyan.
Okay, maybe you will find it and you should talk to them.
All right. Any other questions for others?
Thank you for your insights. Maybe my question is, how do we make sure health practitioners don't over rely on AI? So how do you make sure like doctors don't become lazy or health experts will become lazy? Because then AI tells you this person has diabetes, this person has, breast cancer. So how do we make sure that the AI doesn't make us as health practitioners very lazy to do our job?
How do I package it? So AI is helping, but is not the final sayer. So if the algorithm or the input you give, the output is the patient could be having diabetes, then you need to go further and do the test, confirmatory test. And that one you might find it will need the human touch. It's not relying with AI to do that. So AI will just be sort of like a helper. Ni wa kutusaidia saa zile tuko short staffed. So it is helping us, but the majority of the work we'll be doing is us. And then remember, we have a lot of, it's sort of like renewing every time we are keying information to the AI so that we can be able, the tech people can come up with a logarithm that will be now, giving us the output. And remember, we are always evolving. People are always evolving. New symptoms are coming in. So there's always that renewal of the data that we are keying in so that we can get the information. So it is actually keep us on our toes, if I'm not wrong, than make us lazy.
There was like a doctor strike and interns are not getting posted, right? There's this debate whether they need to be paid, they don't need to be paid. So in that instance, then what starts happening? Because fine, we've implemented AI and it's meant to help us get better, but who checks the quality? Like who is there to ensure this doctor has said, AI has said this person has diabetes, who is there to ensure that that doctor actually does the job? Because if you go to Kenyatta, sometimes doctors are very understaffed. There are too many patients, people are not seen within time. So who ensures quality is done? As much as we are trusting that us as health practitioners are going to do it, but who really ensures it's going to be done? I think that's the
For sure. Go ahead.
So I think my two answers. One, I think training of doctors to help them understand that the models that they're using have their faults. So I think, as Tanya was talking about explainability and things like that, when a doctor understands how the model works and the output that it, and as a clinician, your clinical decisions, like, of course, you've seen the patient, there's what has come to your mind and what the model, will output. If the two of them are very separate, then when you train them on these models, then it helps them understand that they can rely on their own, decision and not always just delegate to the model. That's one. Two, I think, so this has actually been implemented for where robotic surgery is done. Ultimately, the responsibility is on the doctor performing, who is there during the robotic surgery when it's being done. So when you delegate, yes, your tasks to the model, the responsibility of the outcome is still on you as the doctor. So if you choose to not follow up, then the legal implications are not to the model. A machine is on you. So then, therefore, the legal follow up and the justice system then inakufuata wewe as the doctor, in short.
Yeah. So you have to do the clinical judgment. What is your clinical judgment as the physician, as the nurse who is looking at this patient? Just like what she said, if your clinical analysis and examination is not tallying with what the system is telling you, then there's a glitch somewhere.
I also to add to the case, I really like her question. There are cases where the AI agents have done diagnosis better than the doctor. And I think her part is like, how can we assess? How can we evaluate? Like, what's the way forward in that sense? It's tricky, but yeah.
Yeah, at the end of the day, it's you. When the patient leaves the hospital with a diagnosis, with a treatment, the patient isn't going to say the AI told me. The patient will say, the doctor at this hospital, I went to Kenyatta, they told me to take XYZ because I have X. So if anything happens, that patient is not going to come back to the AI, it's going to come back to the hospital. It's going to come back to the doctor. And in that case, you as the institution, the hospital, you as the doctor who is treating the patient, you have to be able to justify the decision or the decision that you have taken. And for you to be able to justify, if you want to say that AI has been, okay, the AI was better, so I chose it, then it ends up
that liability, you're still liable. The person who built the AI is also liable, and it becomes a whole chain of all the parties that are involved, all the parties that are responsible for this outcome. And that's why this collaboration between, as a doctor, as a hospital, I don't want to be liable. Are you giving me a good model? As a developer, I don't want to be liable. Am I creating a good model? That collaboration needs to continue down to the user, so that if anything happens, everyone who touched it is liable. And so you can't just say, because AI was good for this one, I'm also just going to sit back and do that. You have to always, and that's why even when you're using ChatGPT, there's always a clause there. Remember, ChatGPT can be wrong. Double check what it says, because it's now shifting that responsibility from them to you as the user who is using that AI. So that's one thing, as she said, the training, we need to always hammer that down. This is not replacing your work. This is an assistant. It's helping you. Always exercise judgment based on your training, based on what you know, based on what you can observe, and use all of that information to make an informed decision.
You asked about quality. Yes. How do you ensure that? So once the policy on quality is in place, so this will ensure maybe after how often do you ensure and check that the system is operating at its optimal? And this you'll find that the different entities that are involved, the tech, the developer, the tech institution, the institution that is using or applying this AI or the software, and the user come together to do that inspection to ensure that the software is doing what it is intended to do. And they can come up with a schedule either to be doing periodically or twice a year, or how often, or every 2 or so years, they come and recheck the software. Yeah.
I think also in terms of the quality question, I think you can always give feedback. So maybe on case by case, every patient you see, whether the diagnosis you had and the output of the model, whether there was a match, and justifying, especially now where the model is better than you and you decide to go with the model's decision.
What decision? Yeah.
Okay, then you can always justify, yeah, you can always justify that, yes, the model did give this. I thought this and I went with this because of this. And that way then when you have, like in any corporate, when you have anything in writing and your justification and it does make sense, then it does remove the liability from you and someone can see your reasoning and you just didn't do it out of negligence or ignorance.
Last question is, how can we ensure like now the government prioritizes AI in healthcare? Given that so I think it's a long shot, but because I work for a research organization, and I think we're really trying to see how we can power AI in health research. But it's not as it's how can we, I mean, right now we are a group of women trying to talk about AI in healthcare. But how do we make sure that as much as we're talking and people are leaving this room knowing, okay, there's this, but how do we make sure that people beyond us can be able to know this is what we're doing, you guys are doing such amazing jobs. So how better can we make the government or even key stakeholders know that anyway, AI is actually a good thing in healthcare? Like, how do we start having those conversations just beyond people already in this space? Something like that.
The conversation is there.
Yeah.
And I think the first step is the technology, embracing technology. That's the first step. And the Ministry of Health is embracing technology. Currently, what we are doing when a new center is being set up for cancer, the first thing that we ensure in that facility has is technology and network. Okay, so that every data for every patient they see is fed and it's translated to the cancer registry every month. So already we are embracing it. So now getting the AI to every center is the next step. Yes. Nakea is the system that they are using.
Nakea only take data from
Public.
Yes.
Even so the trick that or the challenge that is being experienced is whereby we have institutions that have their own EHR, and then us coming in saying the only way we can receive data from you is when you use Nakea system. So that's where we are having a challenge, but they are embracing it. They are embracing Nakea slowly by slowly. The important thing is we've started the journey.
I see. Oh, the next day. Oh, so something. Yeah, I just wanted to add in on that. So
we work very closely with the government. Actually, most all of our work is in public health system. And the first step, of course, is we are here talking very high level stuff. Yeah. So the first thing is communicating this to the leaders, even before stakeholders. You need to go to the CS, you need to go and tell them about AI in a language they understand. Just understand what is the key deliverable for this CS, right? And then help them see how AI can help them do their work. You sit down with the PS, understand what are the key KPIs for this PS. Show them how AI will help them achieve their KPIs. So unless you're able to digest all this techie information we are talking in a language that is relevant for the president. If you go to Ruto, tell them, show him how AI will enable his digital economy. If you present a very clear use case, then he'll support it. But he'll always be like, this AI you guys talk about, view machine, it doesn't connect to his manifesto, it doesn't connect to his agenda. So you have to really create information pieces for the leaders. Then AI will be put into policy. Then there'll be regulation for AI. Then there'll be a rule that every hospital must apply AI. So it has to come from the top. Even if we do it here at the ground level without starting on top, we won't make it. So we have to start with communicating with the top leadership. Yeah.
Sorry. 30 seconds. Yeah. So my question is, there's a data gap that we've been talking about in terms of research funding. I don't really see a lot of research funding going to things like the things we're seeing, the cancers, the mental health, women's health. I think apart from American University, I think that's the place I've seen that kind of research being done. But we're looking at a lot of infectious diseases, tropical diseases. How do we bridge those gaps of data? What's funded, what's not, how do we get to that?
Can try, but so you'll find that how public health is funded, it's funded based on, or how it has been is what is of interest to the West, right? So if maybe COVID is of interest, they'll pour a lot of funding into it. If TB and TB, HIV, why they're funding it is because they don't want us to take it there. So I think one of the things that has to change is we must now take lead, like how now after the pandemic, now people started saying, okay, we need to start manufacturing drugs for ourselves. I mean, we have something like the National Research Fund. What does NRF fund? Why can't we increase funding to NRF and now fund stuff ourselves? I know now NRF is funding maternal and child care. Can we, we have what it takes. And then when maybe USAID comes and they want to fund research, you tell them, okay, don't come here and you've stated what you want to fund. This is our priority. So we have to also now start prioritizing things, and when they come, they find we have actually a research strategy, so they fund that. But we need to stop that narrative of, okay, these guys want to fund this, so let's go that way, go do what they want to do. So it has to now be Africa-driven, Kenya-driven research. Yeah.
All right. I'll also just quickly add, there are some funding opportunities for research on diseases in Africa, and a lot of that conversation is happening within these people who are giving money. So there's like the NIH is looking into pouring money into Africa data. We have research hub like the Madiva, which looks at multimorbidity in Africa. They also offer grants to researchers in Africa to be able to do that. And of course, the can. So, I mean, that conversation is coming up, and there are institutes that are pouring money into that.
All right, thank you. I think we've come to the end. I'll give my panelists 30 seconds each to do a parting shot. Then we will complete the conversation. So what is the one message you'd want people to go out of this room? Can start from Tara's side or whichever side.
Okay, I'll just start. I guess for me is, first to put explainable AI at the forefront. Don't think about just building something cool. Think about building something useful and being able to justify why you're using it and how it can be applied in the real world applications.
I guess I'll go next. I think what I'll say is when you're going to sell something, you need to convince someone. And for us to convince people that AI actually matters and machine learning and all these good things, then we need to put it in a language that they understand. As Tanya has just said, we need to make it, actually, is it Tanya or Nelly, Dr. Nelly? You've just said that we need to make it relatable. So I think that's what I would say. Take that when you get out of here, make it relatable, make it understandable, make it not too technical, make it easy to understand even to a child.
All I can say is we've seen the use of AI in health, particularly in cancer. It's working. We just need to have an open mind and adopt it. So now let's continue with that discussion with the relevant authorities so that we can roll it out and everyone can be able to access care.
For me, mine is a bit of a tangent from what the previous speakers have talked about. It's to the young minds, i.e. me, in this room. I hope that today has shown us the possibility of what is out there, of what we can build, of what we can do, of spaces that we can plug into. And I hope that we keep building, we keep, putting ourselves into those spaces and growing in those spaces so that we can solve all these problems that we're talking about here. So I think mine will be in line with this year's theme of inclusion, of equity. So as we are doing whatever work we're doing in AI, we are the ambassadors. I mean, women have been excluded for a long time, so we probably understand what we mean by exclusion and why inclusion is important. So let's be the agents for inclusivity, as we're working with our AI models, as we are looking to solve problems using AI, let's always have that eye of, is this thing inclusive? Does it cater for everyone's needs? So thanks.
So thank you. Yeah, AI healthcare is to augment. It's not to replace. Yeah, and I think that's something that we have to have at the back of our minds, even when we are engaging the healthcare providers, the stakeholders, the government. We have to tell them that we are not bringing this thing to replace the doctors. We are bringing this thing to augment, and ultimately is to improve their patient outcomes. So thank you so much for the WiDS Kenya for inviting us. Thank you for all my panelists and the audience for being very patient with us and listening to the end. We've come to the end. Thank you so much. Thank you.
Thank you. Oh my gosh. Those are wonderful, wonderful questions, guys. Let's appreciate our panelists one more time. And actually, this has been the longest session we've had ever since, but it was the best because we are coming out of this session quite inspired, quite enthusiastic about everything that is going on around us, this AI and the stuff, right? So at this point, we'll close the session. It's been a wonderful journey. I have hosted WiDS event. This is, I think, my third year, and I think we are going on quite well, and the community is broadening, which is quite interesting. And I want to take this opportunity. First of all, I'd like to thank our speakers from our opening remark speaker, Dr. Lilian. It was wonderful, great. To our keynote speaker who talked more about what Lilian was mentioning on AI bias, right? It's our call to work in a collaborative manner to just make sure that we are implementing technology well, right? To our technical speaker who talked about the topic that I love the most, interpretability, very key. And she has just said it one more time, right? When you are training those big models, like I was asking Diana, what is cat boost? Don't talk to me about cat boost. Explain what cat boost is and just be normal. when you're talking to people, talking about no, so not that Diana's, it is a call for all of us, right? Let's just not be so much technical with these terminologies, but we try and not with the terms also, but with the outputs that we get out of them. Tanya explained really well that we should be more interested in explainability part of it. And we had a wonderful session where Mutanu and Nelly talked about what they are currently working on. Quite inspiring, guys. It is a call for all of us. I know we are all doing amazing stuff, but I also hope that through the works that interesting women are doing out here, you are also going to like feel so inspired, right? And to the last session, last but not least, was quite, it was the best. The panel discussion, great. We dive deeper into the topic, and I feel like we've exhausted all we needed to have talked about as far as AI equity in healthcare is concerned. So to our wonderful speakers, thank you very much, Dr. Wambui, for moderating it. Thank you, Terry. Thank you, Lilian. Thank you very, very much, right? I'd also like to thank our collaborators and partners in this, Microsoft, University of Nairobi, who supported us this time. Last year, we had Moringa School and Kenya Airways. So organizations have been coming in to support